So good morning, everybody, and welcome to the Advisory Committee to the CDC Director. It's great to see all of you, if only virtually this time. Next time, we're going to try to do this actually in person. We wanted to start off the meeting today by welcoming a new committee member, Dr. Josh Scharfstein, who successfully made it through the nomination process and is joining us as the final member of the committee. We're honored to have you here today, Josh, and without putting you too much on the spot, would you mind saying just a few words of introduction for the group?
Thanks. I thought you were going to say I made it through the Zoom background process.
Well, you did that too.
I had to go find the Zoom background. Well, thanks so much. It's an honor to be here. I'm Josh Scharfstein. I'm a professor of the practice in health policy and management at the Johns Hopkins Bloomberg School of Public Health, where I'm also the vice dean for public health practice and community engagement. I have worked at the federal, state, and local level. In my career, I was the health commissioner of Baltimore City, the health secretary for the state of Maryland, and the principal deputy commissioner of the U.S. Food and Drug Administration. I'm also a pediatrician by training.
Great. Thanks so much, Josh. And once again, it's wonderful to have you here. So our first order of business is to do the roll call and the conflict of interest disclosure. I will start. I'm here today, and I have no conflicts of interest. Next, Dr. Adamora, were you able to join yet?
Hi, yes, I am on. I hope, do you see my Zoom background? I don't see myself.
We do, it's perfect.
Okay, right, I'm sorry, apologies for being late. So my conflicts are, I've received personal funds and research funds from both Gilead and Merck.
Thanks so much. Dr. Albert, I believe, is on clinical service this week, and so will be unable to attend today. Mr. Dawes.
Good morning, I'm Daniel Dawes, and I have no conflicts to report.
Good morning, Daniel. Ms. Gary.
Good morning, sorry about that, getting off mute. Crystal Gary, I have no conflicts to report.
Great, thank you. Dr. Goldman.
Good morning. I'm sorry that I'm not on camera. I have no conflicts to report. Thank you.
Thanks, Dr. Goldman. Dr. Hardiman.
Good morning, Dr. Rachel Hardiman, and I have no conflicts to report. Thank you.
Good morning. Dr. Martinez.
Good morning, David, and welcome to our new member, Joshua. No conflicts to report.
Thanks, Octavio. Dr. Meadows.
Good morning, I'm Dr. Rhonda Meadows. I have no conflicts.
Good morning. Dr. Marita.
Good morning, everyone. I'm Julie Marita, and I have no conflicts to report.
It's good to see you this morning, Julie. Dr. Sachs is in Kinshasa this week, and so will be unable to attend the meeting. Dr. Shah.
Hi there, Nirav Shah. I have conflicts to report as a director of STERIS and on the board of KINSA.
Thanks, Dr. Shah. And Dr. Scharfstein, conflicts of interest.
Not sure whether this counts, but I'll say it anyway. I do some consultancy for Sachs Policy Group based out of New York, which is really exclusively with large healthcare systems on population health issues.
Great, thanks so much. Dr. Taylor.
Jill Taylor, no conflicts to report.
Good morning, Jill. Ms. Valdez-Lupi.
Good morning, Monica Valdez-Lupi, no conflicts to report.
Good morning, Monica. And thanks, everyone. So the good news is that we are well over our quorum for the meeting and we can proceed, all right?
Excuse me, David, I should probably also report on the board of directors for the Infectious Diseases Society of America.
Perfect.
I don't think that's a conflict, but I'll just let you know.
Thanks so much, Ada. And just as a housekeeping reminder for the ACD members, during the Q&A session, if you wouldn't mind, just please keep your video on so that folks watching can see you, and use your raise hand feature, which will enable me to know that you want to make a comment, and then I can call out you. So we have a lot of important stuff on our agenda today, including action on the formation of our 3 working groups. So I'm going to dive right into the agenda. And speaking of important stuff, boy, our first agenda item. As with the last meeting, we wanted to start off today with an update by the Director of CDC, Dr. Rochelle Walensky. This part of the agenda provides time to talk about some of the current issues and events at CDC. Dr. Walensky, thanks so much for spending time with us today. welcome, and we really look forward to your presentation and discussion.
Thank you so much, Dr. Fleming. Good morning, everyone. It's great to be back with you today, and I'm really excited for another robust day of discussions. Your last meeting was full of insight and engagement, and I really can't wait to see what this one brings. So while we are, once again, as you mentioned, David, meeting virtually, I do look forward to the time where we can meet in person, and I'm quite hopeful, as it sounds like you are as well, that might be for our next meeting. So I will look forward to that. I know I've expressed my gratitude to all of you before, but I feel like I should do so again. I remain so appreciative that each of you has committed to sharing your collective expertise with us here at CDC. And again, I extend my gratitude to our newest advisory committee member, Dr. Josh Scharfstein. I'm really delighted to have Josh joining this important group of advisors to me. As you all know, we reestablished the advisory committee to the director because we recognize how important it is to have advice of a group of knowledgeable experts on a very broad range of topics. We want and need your input on our current activities and your feedback on how we can truly optimize our impact. As we thought about where we could most use your help, we identified 3 critical areas for how we function at CDC: equity, data, and laboratory quality. I understand you've already established the working group on equity, and later today you'll vote on whether to establish work groups on data modernization and laboratory quality. Of course, we know there will be more questions and more areas to consider as we continue our work together, and I'm truly grateful for your sharing these important priorities with us. I could not be more excited about the noteworthy group of people who have agreed to be part of the ACD Health Equity Work Group. First, as an indication of your collective commitment, I find it truly remarkable, actually, that 9 out of the 15 of ACD members chose to actually do double duty and to be part of this work group. So truly thank you, and many thanks to Monica and Daniel for taking on the role of co-chairs of this important work group. And then it was truly incredible that the notice in the Federal Register brought an astonishing number of applicants given the really quite short deadline. We received 109 applications, and each of those applications and applicants would have been a stellar addition to our work group. The 10 people selected for the work group do the work of health equity every single day, working with tribes, working with people with uncertain housing, working with people with disabilities, working with youth of our country, and bringing health services to those who are underserved. Just to touch on a few examples of the experience that are being brought towards this effort. The list is impressive and testimony to the recognition of the need for this conversation. I believe that many of the work groups are actually listening today, and I'm awed by what you will bring to the table, what you already do bring to the table. So thank you very much again for sharing your skills, your commitment, your expertise, and your professional experience. And especially I want to thank you for bringing your passion to this work. I have heard great reports from your first meeting, and I'm looking forward to what will happen in the months to come, and also to your vote later today on whether to form the work groups on laboratories as well as on data modernization. Of course, these are not the only areas that are receiving attention. The lessons learned from the COVID-19 pandemic, along with the feedback I've received inside and outside the agency over the past year, have made it very clear to me that it's time to take a step back and strategically position CDC to support the future of public health. As we enter a different phase of the pandemic with an eye towards future health threats, we're looking for advice from inside the agency on how best to transition much of our COVID-19 programmatic and scientific response activities from the centralized incident management structure to the agency's CIOs. To that end, I've asked Dr. Barbara Mann, our incident manager, to work with senior leaders across the agency to develop a transition plan to align our COVID-19 activities with our agency functions. We expect to make this transition in June when Dr. Ian Williams will take over as the COVID-19 incident manager. I'm delighted to note that Barbara will join you later in this meeting to talk more about what's happening and to update you on the state of the pandemic. In addition to looking at the pandemic response specifically, I've also asked Jim McCrae, a senior and longtime leader from the Health Resources and Services Administration, and senior CDC leaders Deb Howery, Robin Bailey, and Sherry Berger to hold confidential one-on-one interviews with our employees and other key stakeholders inside and outside the agency to gather feedback on our agency's processes, systems, and structure, and to solicit suggestions for strategic change. You will hear more about the recommendations and our actions at later meetings, where we will devote time to dive into the questions that came up through this effort. This is the work that will position us strategically for our future and to advance our future goals. In addition to these efforts, recently CDC updated its strategic plan to reflect where we are in this moment of the pandemic and public health, and to emphasize our agency-wide commitment to health equity and workplace and workforce diversity and inclusion. In 2022 through 2027, CDC's strategic plan advances science and health equity and affirms the agency's commitment to one unified vision: equitably protecting health, safety, and security. The plan continues to leverage 5 core capabilities of the agency, reflecting our commitment to equity and diversity and lifting up where we have invested through the COVID-19 pandemic. These core capabilities are building and maintaining a diverse public health workforce, developing and deploying world-class data and analytics, maintaining state-of-the-art laboratories, responding to domestic and international outbreaks at their source, and finally, strengthening our global capacity and domestic preparedness. Strengthening and modernizing these core capabilities provides an opportunity to leverage the capacity we've built with critical investments in support of the COVID-19 response and position us for a successful future. Those investments include developing COVID-19 vaccine implementation infrastructure, expanding our lab capacity to support genomic sequencing, enhancing CDC's data modernization initiative, and strengthening workforce capacity within CDC and through response-related funding to health departments. And we've made enormous strides in diversifying our leadership with the selection of Robin Bailey as the agency's Chief Operating Officer, Les Dauphin as the Director of the Center for Surveillance, Epidemiology, and Laboratory Services, Leandra Mina as the Director of the Division of STD Prevention, and Jose Romero to lead our National Center for Immunization and Respiratory Diseases. In our last meeting, I mentioned our new Center for Forecasting and Outbreak Analytics, or CFA. And I had the opportunity on April 19th to be at the White House for the official launch of the new center. Now, CFA will bring together next generation public health data, expert disease modelers, public health emergency responders, and communication experts to help make sure we never again face a public health emergency unprepared. The creation of such a center, like the creation of this advisory group, has been one of my top priorities since becoming CDC director in January 2021. CFA will be there with analyses at every stage of a health threat. Early on, the center will assess an outbreak and its potential to reach an epidemic status. Later, the center will be able to compare the expected impact of different interventions and help jurisdictions decide whether and where to direct their resources. And the center will provide data on the epidemic and how we will know when an outbreak might be over. In this way, CFA will help reduce the potential for social and economic disruption from health threats. CFA has already been proving its value. During the pre-launch phase, CFA helped us anticipate the timing and impact of the impending Omicron surge. Shortly after the variant's arrival here in the United States, CFA partnered with HHS Assistant Secretary for Preparedness and Response and CDC's already robust modeling and data analytics team. And we were able to alert public health leaders and their partners, providing advance notice of the timing and magnitude of the surge, as well as the severity of the disease itself, allowing them to plan. And this is just the beginning. Through CFA, CDC will develop a program to provide insights about disease events for the public and work closely with partners across the federal government to fortify preparedness activities. Synergistic with our ongoing efforts at CDC, this new center has the potential to improve and save even more lives in ways we can only imagine at this time. So I look forward to watching it grow along with our data modernization initiative that will strengthen the data sources available and make sure the pipes are in place to feed those data to CFA working collaboratively. So it's an exciting time for CDC, and I'm so grateful and so glad to be a part of it and to have you a part of it. Let me close by once again thanking you for each of your willingness to participate on this committee. Over the next few years, we will come to know each other very well, and I very much look forward to that. So with that, I will pass things back to you, Dr. Fleming, and look forward to conversation.
Thanks so much, Dr. Walensky. I'm going to go ahead and open the floor to questions from the members. I'm tempted to ask, with all these things going on, how do you decide what the first thing to do each morning is? But I'll let others ask more insightful questions. We were having a little bit of internet connectivity problems during your presentation. You were coming through, but occasionally stopped and then caught up. So if you see people looking oddly, they're waiting for the voice to catch up. So hopefully that won't happen too much. And as I said, for members who would like to ask a question, please go ahead and raise your hand. Looks like we have a little bit of a shy group this morning. Ada, to you.
So I have one question, Dr. Walensky. The CFA sounds fantastic and sounds like it's already done great work. Do you see the need for additional resources for it, especially in this era where the sort of funding for COVID is sort of questionable?
Yeah, thank you, Ada. So yes, we have early startup funding from the American Rescue Plan. And I think resources, both for our data modernization efforts, as well as for a longitudinal plan for CFA are going to be essential. First of all, the data are going to have to fluidly flow to it, because the efforts here will only be as good as the data and surveillance data that we have. So it's going to be a data issue, as well as working towards longitudinally available personnel to be able to staff it and to be able to work collaboratively and innovate within it. So I am I'm very interested in maintaining not only the funding that we have, but in growing it. The team that we have right now is, as they frequently tell me, small and mighty. And we are working towards expanding that team, and it's actively ongoing right now. But like so many things in public health funding, it tends to not have the durability that it needs. And so I think the durability is going to be essential for us to be able to, predict, prepare, innovate, and inform. And so that the sustainability of that funding is going to be essential.
Yeah, that durability was what I was referring to. Thank you.
Thanks, Ada. And that has been the problem in the past, obviously, we've experienced an outbreak and financing has become available, but it's oftentimes one time, and hopefully working with you, we can make that not be the case this time. Julie.
Morning, Dr. Walensky. Congratulations on all that you've gotten done, even in the midst of the pandemic. I think what you outlined is a lot of progress, so it's impressive to see. So thank you for all you're doing and the progress that you've made. I'm equally excited about the CFA as well. I feel like that's just wonderful work and amazing what you were actually able to accomplish again. My question relates to just authorities, and I want for data. And I'm wondering if you had hurdles to overcome as you are trying to do this forecasting for the Omicron, because I think some of the challenges that have been experienced by governmental public health in the past is related to the authorities of public health to access data. And I don't know if there were some new authorities that CFA has been granted or you've been granted to allow you to overcome some of those issues.
I am so grateful that you asked this question, because I think that this is one of the key challenges that I have seen in coming in here 15 months in, is things that are expected of CDC, that things that are data that people have expected us to see from us that we actually don't have the authority to report on or collect. And so one of the things that I know you'll hear from Dan Jernigan with regard to our data modernization efforts, and I think we will be able to connect the pipes where all the data could flow. But if we don't have a standardization of those data, or those data aren't forthcoming, even if the pipes connect, if there's the right things are not flowing through them, we will not have the capacity to report what we need. Even yesterday, I was in a conversation as to whether after the public health emergency ends, whether we will have the capacity to report all of the data that people are expecting of us. And certainly I've heard from some jurisdictions that, people are interested in scaling up their wastewater surveillance, but some jurisdictions are not interested in reporting it to us. So I think that these authorities are going to be one of the very key issues that are going to be among our stumbling blocks as we try and report what through our data modernization efforts, and again through CFA. I think that's key and something we're actively working on.
And maybe something that the working group on data and surveillance modernization can provide some advice on as well. Yes, important issue.
That would be incredibly helpful. Yeah.
Josh.
Great. I wanted to ask another question about CFA, this time from the state and local angle. I remember when I was health commissioner of Baltimore, and there was a researcher who had figured out some equation to predict heat-related deaths. And so he told us in the city every morning he would send me whether they were predicting heat-related deaths that day. And if it was going to be really hot, we would open cooling centers, we would issue press releases. It became, something that we really were known for at the local level. And it was based on getting, good forecasting information about heat-related deaths. And I wonder, as you think about this great resource, which we're glad to have contributed some great faculty to at CDC, how do you envision it working with states and localities to sort of strengthen, what they do, how they can react, and sort of, give something to them to be able to pivot and then translate it for their population? How do you see that interaction going?
That's a great question. And actually it dovetails with two things. First, I love the question because I want to sort of articulate that while this was stood up in the time of a pandemic, this resource is intended to be both for infectious and non-infectious forecasting, just as you assessed. If we said heat related, we want to do it for both. So I want to be very clear about that. Second is that it is intended to be innovative, both with regard to how we work with industry and partners, as well as how we work with academic partners, which we at CDC have done less of in the forecasting. So that is something that we want to do more of. And then third, to do this inform, as we've seen a lot of models over this pandemic, if they're at the national level, but it's sort of like, one area of the country is in trouble, but the other area of the country is fine. That's the average doesn't really help the local public health partner. And so what we really want to do, and that's really where I think communication is to say, and also to make sure that the models may be applicable. If we have a user interface where you at the public health department could insert your inputs in a user interface, then we could potentially have those models be applied to your local situation. So all of those goals are on the table for what CFA is working to stand up.
Thank you.
Thanks, Josh, and thanks, Dr. Walensky. I was going to ask that same question about the non-infectious perspective. So I'm just delighted to hear that that's on the agenda, and I think that we really welcome by states and localities as well. Octavio.
Dr. Walensky, well, congratulations as well, especially on the CFA, really exciting. It makes me think of an opportunity, especially when you're standing up a new center, to be thinking about really effective communication. So I'm wondering what your thoughts are on that, especially as it relates to recently, because of the pandemic over the course of the last 2.5 years, how trust is also becoming an important component. And obviously the CDC needs to be trusted and to continue that. And I was just wondering what your thoughts were, especially now as standing up a new center, of how that plays into the overall image of the CDC.
Yeah, I think that communication has really been one of those areas throughout this pandemic that people have now really been talking about. Who are our audiences? Who do we need to sort of communicate with? But communication as part of the center is actually one of the key goals, is to work with a communications team to be able to articulate for the proper audience. Like, who is the audience here? Is this the public health departments? Is this, because I think the communications are going to differ depending on who we're talking to. And I think that's true of our day-to-day work as well. Is this guidance intended for school systems? Is this guidance intended for parents? And how do we communicate differently with each of those? So we are working hard on understanding the audiences and communication strategies therein.
Dr. Walensky, thank you for your passion and all you do. I really just need to make a comment now because Octavio asked my question, which was really about communication and getting CDC back to being the trusted voice. And I think that the CFA as a source of data directed to multiple target audiences could have a great deal to do with that, to restore the trust in good science and get people to understand that science is a part of our lives. So thank you very much. That was it.
Thanks, Jill. And I was hesitating to call on you until Dr. Walensky's internet came back up, but you were faster than I was on that. So thanks.
Sorry.
Daniel.
Sure, thank you. And Dr. Walensky, I want to thank you so much for prioritizing health equity as one of your three important issues moving forward. And it really dovetails into the CFA as well. I'm curious because, you know, from my standpoint, we've worked with groups across the country when it comes to data literacy, and we've seen how it hasn't been prioritized. And without a working knowledge of data to drive decision-making, I believe that the movement for health equity is hindered. And so we've come up against issues dealing with data sovereignty with Native American communities, the lack of community engagement early on from communities who are disproportionately impacted by COVID and of course other comorbidities. And so I'm curious if you could talk about how these disproportionately affected communities are a part of the CFA and have been helping to drive the agenda moving forward and the process and so forth.
First of all, thank you, Daniel. Thank you for your leadership in our health equity subcommittee. I'm grateful for that. So this has to be a key part of it. We have said from our workforce standpoint that our workforce has to be as diverse as the communities that they serve. And so if we have public health workforce from and working in those communities, they will understand their data and and in fact, I do want to then lead to data sovereignty because I think that is key. There's no intention here to have anyone lose data sovereignty. The whole point is that we work together collecting the data synergistically so that we at CDC can feed back to you and say, you know, this is how you're faring compared to local communities versus not. So the whole intention is to be synergistic in the data, not for anybody to necessarily singularly own it. But if it comes to us sequentially, then it's just a further delay. And we've really noticed that being a challenge. So we want to work collaboratively with local health departments to understand their data with them, to collect them standardly so we can cross compare, other health departments can define how they're doing, to be able to forecast at the local level. Because if doing it at a sort of national level is just not going to help the local communities. The sort of weighted average is not, you know, locally relevant in terms of their policies. You know, as Josh said, you know, if you have a heat related problem in some community, that doesn't help a different community, right? They don't know what to do.
Thank you.
I'm wondering, you had mentioned that, Monica, I will get to you in 1 second. Let me just quickly ask a question because I was intrigued. You mentioned that after a couple of years now, CDC is transitioning off full agency-wide mobilization for COVID to a more measured kind of response. And Dr. Mann will be providing some of that guidance on that. As you said, she'll be here later. But I was wondering, just from your perspective, if you could give us a snapshot right now of what that looks like for the agency. I can't imagine having, you know, people having been doing this, you know, full speed for 2 years and now having maybe a little bit of a light at the end of the tunnel for some return to normalcy. How are you and the agency thinking about what the next stage in the COVID response will look like? And will this give you a chance to do a little bit of rest and relaxation and get back to all the other things that the agency has to be working on as well?
So maybe I'll just start. First, I know Barb will give you a lot of details on this when she comes, but let me start by saying, first, the work of the agency continues, even though many people are hearing about COVID, we haven't slowed down. In fact, I will just note that over the last year, we've had 63 foodborne outbreaks that we have been involved in. So METCH is still going on. It's also the case that we have had over 2,000 people in our response at any given time throughout the pandemic. 2,000. So what we're working to do is the activities of this will be more streamlined, and they will be brought to to science and programs, where people will be both in program and working on COVID, or if we have a vaccine task force that will be working on vaccines for other vaccines as well as for COVID. So what we really need to do is have fewer people sort of solely focused on detail on COVID, 2,000 of them right now, and have that work back. I say back to program, but it never really, some of these activities never really were in program, but they need to find a natural home, right? Because the activities do need to continue. So we will still have an incident management structure. We still need to have an incident management structure. And I'm really grateful to Ian Williams, who has agreed to be the incident manager. We're trying to bring many of the activities into the program that will then roll up to incident management when when there's a communication or a new guidance or whatnot, so that we don't have 20% of the agency on detail at any given time for the response. And so that's actually, and a lot of that work has happened already. A lot of the streamlining has happened already. And Barbara can give you more details on that. But I think 2.5 years into this, we need to, and in fact, really the country working towards closer toward the steady state in where we are, that we need to do this at CDC as well.
Yeah, thank you. Really, really welcome news. I appreciate that, your response. Monica.
Yes, thank you, David, and thank you, Dr. Walensky, for sharing those updates and for emphasizing the importance, I think I heard, in terms of building equity into the way in which you approach implementing your strategic plan and the services that are related to health, safety, and security. And I had a question about the organizational review that you included in your updates to us that our colleague Jim at HRSA will be doing over the next month or so. And was just curious how that might be different in terms of previous assessments that have been done and the action steps that you imagine will follow vis-a-vis the core capabilities that you outlined in sort of this future of the CDC and kind of shifting into this more steady state, because I think a lot of state and local health departments are taking stock at the last couple of years and revisiting organizational capacity and capabilities. So I was just wondering if you could say a little bit more about this organizational review and how that might be different and also inform the work ahead.
Great, thank you for that question. So we're partaking in 3 really activities at the same time. The first is what I just outlined for Dr. Fleming with regard to, how can we bring the response activities to program, or at least many of the response activities to program. The second is many of these listening sessions that Jim McCrae is doing. I'm very grateful to him. And that is, what did we learn through this pandemic with regard to how we implement new guidance? We have had to work, CDC has never been in a pandemic the way we've had to be actionable so swiftly with such evolving science. And so are there lessons that we have learned on things that went really well, on things that could have done better, and that we could have done better, and truly on ways that we could streamline our other guidance and processes that we learned from this pandemic that we should take back to other ways that we operate? And sort of what are the lessons that we learned in the last year and a half? We want to formulate those and understand those, either for next waves, though I hope there aren't too many of those, but also to see what we can and should learn from and bring back to our standard operations. And then it's really not lost on me that we haven't had a review of the agency in a while in terms of our systems and structures and processes. We've hired about 10% new people, new FTEs through this pandemic. We have a new center for our CFA that needs to find a home. So while we're doing those two activities, we're really doing some listening sessions in this review to understand what it is, where some of these things should live, how we integrate some of these structures back into, or I should say, into our CIOs. And is there anything more that we can and should be learning? I have a really open mind in terms of what we haven't had over the last 15 months time to digest some of these activities that one might have wanted to do when I started. So this is really the moment that we have taken to do all of those activities, those listening sessions at once. And I don't necessarily, we're not through them, so I do want to keep an open mind as to where we go. But I do think we've had enough critique. Certainly everybody, there's been enough magnifying glasses and enough discussion that I feel like we should do an internally facing one as well.
Yeah, thanks so much. Any last questions for Dr. Walensky? Wow, thank you so much for spending time with us this morning. This is we're incredibly thankful, and you just give us a great benefit and luxury to us to make yourself here during this time. We look forward to our next meeting when we can do this again, and happy to in person. Yes, that's what we're trying on. I'm looking forward to and maybe even a dinner or something before, so we can bond as a committee and bond with the CDC leadership, which is something that I know we're all looking forward to. So thanks again, Rochelle. We really appreciate you being here. And we have a busy agenda, so it's time for us to move on to the next item.
Thank you so much, everyone.
Okay, thank you. And so let's now move on to our next topic, which is data modernization and surveillance. We, as you remember, had an initial presentation on this at our last meeting, and today we wanted to move forward, including officially forming an ACD working group on this. And some good news in that regard. As we've already shared with the committee, ACD members Nirav Shah and Julie Morita have agreed to serve as co-chairs for this group, which is fantastic news. Thank you so much, you two. I really appreciate you making this contribution. So to start us off today, it's my pleasure to once again introduce the lead CDC official on the Data Modernization Initiative, Dan Jernigan. Dan's going to get us up to speed and talk a bit about the specific terms of reference for this work group. So over to you, Dan.
Great, thanks very much. If you could go to the next slide. So you just want to start off, say thanks to a number of folks at CDC that have helped put this materials together. Agnes Warner, Taylor Mann. I also want to introduce our new permanent Associate Deputy Director for Public Health Science and Surveillance, Dr. Jennifer Layton. And so she comes to us with a lot of experience as a state epidemiologist and also as a chief medical officer for the city, the Department of Health in the city of Chicago. So the task that we have at hand is a big one, and it's one that touches on multiple parts of public health. And so I look forward to hearing from all of you about how CDC can have the greatest impact at improving our surveillance and our data systems to have faster, better data for actionable intelligence for decision-making at all levels of public health. If you could go to the next slide. The first, just to do a quick refresher on the DMI priorities that were presented previously. I spent some time on this the last time we met, and so I won't go into too much detail again, but they will underpin the rest of today's conversations. The questions that we have will actually mirror along these areas, these priority areas. So as you may know, in 2021, CDC published its first Data Modernization Initiative Strategic Implementation Plan, and that's available at the website that's listed there. This comprehensive new approach is framed around 5 critical priorities for work across CDC and across our state, territorial, local, and tribal or still partners. Those 5 areas are building the right foundation, and you can see under each of these are the outcomes that we want to see happen. Building the right foundation is essentially getting those pipes, like Dr. Walensky mentioned, from healthcare sources of data and other sources of data into a place where it can land. And for that, we are implementing a cloud-based infrastructure at CDC and supporting our states through cooperative agreements and other funding to do that cloud-based initiation as well. Once that data is there, we look to see using shareable approaches to data analysis and visualization tools that can be reused across different programs so that we can move toward actually busting those programmatic silos that are out there. For the second priority, Dr. Walensky mentioned all of the activities happening with the Center for Forecasting and Outbreak Analytics, and we really look to that group to help push the innovation for predictive analytics, for scenario modeling, and for other efforts for forecasting. It's in that space also that we are supporting a lot of standards development, working with our Office of National Coordinator folks at HHS so that we can get public health into the electronic health record environment so that public health is a part of that healthcare ecosystem. Those standards development activities will take some time, but they have to get started now. The third is to develop a state-of-the-art workforce. The fourth is to support and extend partnerships to address policy issues, really looking at what are all of those non-technological levers that we can pull that will help us to use that technology best and get us to that better, faster, actionable intelligence. And finally, managing change in governance, because we all recognize that what we're trying to do at CDC, what's needed at state, territorial, local, tribal health departments is to think about surveillance differently, think about how we receive and share data differently, and understand that this is a change management issue that requires a lot of understanding of where people are and where we all need to go and helping people to get there. So our commitment to data modernization includes, but it's not limited to these investments. These investments include data systems, they include strategies and capabilities, those policy levers, like I mentioned, and clearly the multi-sector partnerships that are in place now through our DMI consortium, but through other mechanisms that we're using as well. So the DMI strategy is changing collaboration and innovation across CDC and hoping that we are driving that change also at our state, territorial, local partners. And it includes an agency-wide commitment to setting and then achieving specific objectives and key results. If you could go to the next slide. So maybe the biggest difference in today's DMI efforts is the community we have around this effort toward shared success. Many of you have been a part of the dialogue. We've talked with a lot of folks, had multiple listening sessions, and there have been multiple recommendations that have been provided to us or have been published. Those support DMI with valuable recommendations, and it does provide a shared vision for what public health can be. We're listening and incorporating those recommendations as we implement DMI. And you can see here just a snapshot of just some of the papers that have been part of this thoughtful input. Listening to our partners and the wider conversation will ensure that DMI is responsive, flexible, and attuned to the needs of public health and our nation. Next slide. So we'll have an opportunity to go more in depth on this later in the presentation, but I feel like it's important for us to touch on how CDC's funding and structure have impacted our modernization efforts so far. So when it comes to implementing DMI, one of CDC's biggest strengths has shown itself to also be one of our biggest challenges. CDC is made up of many different centers, each with different areas of expertise. And that is the plural, the S in the centers for disease control and prevention. This way of working has allowed us to go deep in our science, which is a benefit. The good thing about this is that science and surveillance are ingrained in every part of our agency. A survey done a few years ago found that about 1/4 of CDC staff conduct surveillance-related activities, and nearly half of CDC's health scientists, about 45%, and medical officers, about 50% of them, work in surveillance-related units, underscoring the importance of CDC scientists to the surveillance enterprise. However, the challenge comes from the fact that each center often has its own disease-specific funding streams, which over time has resulted in more than 100 different surveillance systems tracking thousands of diseases and conditions. This type of categorical funding can result in what we call data silos and a lack of connection across different parts of the agency. That then translates into heavy burdens for our data providers at the state and local levels, who must often report to these multiple systems in multiple different ways. So further, this way of working has become the status quo across all of public health, and these siloed systems exist at every level, from the state, local, and all the way to the national level. Next slide. So CDC is known for and trusted largely because of our expertise in tracking health threats through our surveillance systems and in sharing these data and discoveries to inform decision-making. At the same time, CDC maintains more than 100 surveillance systems for different uses. It creates a reporting burden, it creates duplication, and it can create discrepancies among the data elements and the need to use multiple information technology systems. When we evaluated surveillance estimates as part of CDC's surveillance strategy, we identified that CDC's active surveillance systems cover broad ranges of topics falling into 4 categories. There are infectious diseases systems, about 60% of them. There are non-infectious health conditions, about 23%. There are both infectious and non-infectious diseases and conditions, around 2%, and risk factors and exposures of around 17%. Some examples are provided there. The examples may not be exactly in the right place, but they are there in order to show you the breadth of the different kinds of information that we are collecting. So if you could go to the next slide. Creating an additional challenge is that the world of data continues to proliferate and change rapidly. We're in the middle of a data revolution. This creates opportunities to advance public health in ways that were hard to imagine a generation ago, but it also brings increased complexity to our work. For example, data informing the COVID-19 response originate from traditional and non-traditional healthcare settings, community and municipal organizations, the private sector, and many different electronic health record systems. Big systems and small, both electronic and paper. The central challenge for CDC and for public health at large is to take these vast data delivered at different times through different channels and intermediaries and of different quality and completeness and turn them into useful, actionable information. An enterprise view of the world of data can offer insights that make information more timely, accessible, content-rich, and cost-effective. The big question we're addressing through DMI is this, is how can we harness our strength, this deep expertise built up over decades, while overcoming these challenges so that we can truly operate as one CDC and as one public health community, along with our partners at state, territorial, local, and tribal. You can go to the next slide. So that brings me to the main reason we're here, the Data and Surveillance Workgroup. The Data and Surveillance Workgroup, or DSW, is being established to provide work products to the advisory committee of the director regarding agency-wide activities related to the scope and implementation of CDC's data modernization, or DMI, strategy. There's a document with the terms of reference for this workgroup that you will have already received or will be receiving. And through this work group, we will be able to look at our existing challenges from a more holistic perspective and find solutions. If you could go to the next slide. The work group's efforts will assist the advisory committee in identifying innovative and promising modernization practices and approaches that align with the principal pillars of DMI. It'll also seek opportunities to advance modern, harmonized data policies and practices in support of public health activities. And the work group's primary charge is to provide input to the advisory committee regarding potential solutions to issues and questions. So keeping equity as our focus, the work group will convene a balanced group of subject matter experts in public health science and practice, policy development, analysis and implementation, and surveillance and informatics. We'll have members from jurisdictional government agencies, from non-government organizations, academia, and the private sector. These experts will work with the advisory committee to develop advice and recommendations to CDC to support the effective execution of CDC's data modernization strategy across the agency, ultimately playing a key role in the agency's work with public health, healthcare, academic, and private sector partners. Next slide. I want to use this time to walk through a set of slides through some of the main issues that are listed here. We'll walk through those, and then the related questions that the work group will be asked to consider. Next slide. So the first issue we want to look at has already been raised in the preliminary questions to Dr. Walensky, and that is the CDC does not have the direct authority to require jurisdictions or other entities to report data. CDC, state, tribal, local, and territorial public health agencies are still depend on and are bound by laws, regulations, and policies which determine the content, form, and manner of the data that they collect, report, and use. The variation in these laws, these regulations, and these policies across jurisdictions and levels of public health may create impediments to data sharing and exchange and limit efforts to gather data at the regional or national level on critical elements such as social determinants of health, often depending upon their interpretation. Next slide. We are in a very different place now than we were before the pandemic. There are lots of data. I won't go through all of these here. Electronic lab reporting, case reporting, now electronic case reporting, ED, syndromic information, immunization records, healthcare data, hospital capacity data. Much of this data really gives us an incredible national picture of what's going on, but a lot of this is made possible through emergency orders that may, when the pandemic public health emergency is ended, those authorities may end as well. Next slide. So a question for us is, how can CDC support common approaches to data sharing and access for public health data, particularly through supporting policy and system approaches consistent with applicable laws and regulations to build trusted networks for data exchange and address vulnerabilities created by variation across sectors and levels of public health? So that is the question for our issue number 1. The next slide. For issue number 2 on data exchange, this is data exchange has been a very burdensome and time-consuming process. The burden and the friction of exchanging data forces staff across the public health enterprise to focus a significant amount of time, effort, and resources on data management rather than conducting public health surveillance and response activities. Much of the time of the state and local health department staff is just getting the data in so that they can work on it rather than letting the data work for them. So we need to be able to change things so that some jurisdictions aren't spending 80% of their time just getting the data in shape in order to analyze it. CDC is working with partners to explore the design and implementation of a modern public health information ecosystem that can be leveraged to reduce the cost and complexity of STILT's operations. One component of that information ecosystem could include a centrally hosted infrastructure and services which are provided to jurisdictions by CDC. Next slide. This is a picture of a graph of a framework that's in development. This is a discussion that has been ongoing with CDC, with our STILT partners, and is now under active discussion through our DMI consortium, which includes multiple different public health partners plus other partners in this public health ecosystem space. This North Star ecosystem model, often referred to as the North Star architecture, describes the who, what, and how of a future state public health ecosystem where data flows and information systems are coordinated, connected, and interoperable across healthcare and public health at all levels of government. I'm not going to go into details on this, but the model maximizes the benefits of cloud computing, open architecture, and industry standards for data collection, exchange, management, and analysis, and it proposes a spectrum of options for STILT participation that preserves their control of their data and their decision-making autonomy. This work is being done jointly between us and the Office of the National Coordinator, along with our DMI consortium, in order to assure that we capture the needs of the entire ecosystem and that we come up with decisions or directions that CDC can help support through the building or the development of necessary components as we have funding available to do that. This is founded on the lessons learned from the COVID-19 pandemic, and it draws inspiration from and builds on the successes of the COVID ELR, the electronic laboratory reporting, which enabled a dramatic acceleration of automated lab reporting, the efforts to modernize the National Syndromic Surveillance Program, which provides most of the emergency department encounters in the US right now, and the increased scalability of the National Notifiable Diseases Surveillance System, which receives 10 times the usual case volume due to COVID-19, among others. We want to offer a range of support through the data modernization efforts to our state and territorial and local partners. We realize that most of the activities in those departments of health are supported with federal dollars. We want to be able to have solutions that address at least 3 kinds of models of how data can be shared: a local hosting environment where the state is responsible for their own systems, but are not quite cloud enabled yet; a hybrid approach where they maintain their own cloud, but we are able to have services that they can use that help them increase the work that they can do and decrease the amount of burden that they have in getting data together to be used. And then finally, like I mentioned before, a locally, a central hosting, which would be a cloud-based platform that would now enable states and locals that do not want to do their own hosting, that would have the capability then to use all the services available and those case management tools that are being developed. So we'll be working on this over the next 2 years. It's going to take time and planning, but we look forward to your input on this. If you go to the next slide, the question that we have in that context is, what role should centrally hosted infrastructure and service play in a modern public health information ecosystem? Everybody is familiar with how using the cloud, whenever you use Amazon, or whenever you do Expedia or Travelocity, those are centrally hosted infrastructures. Is there a role for that for public health? And how can the structure and use of a modern public health information ecosystem support and ensure that partners receive added value through participation, for example, through the sharing of harmonized data to jurisdictions from CDC? So how can we have a good national picture of what's happening at the same time as our state and local partners are getting all the data that they need in order to do the important public health work that actually happens at the local and state level? Next line, next slide. So in terms of issue 3, forecasting and analytics, policymakers and individual citizens often rely on CDC for guidance and information that depends on the use of models, forecasts, and analytics. And some clear applications of these tools for situational awareness, early warning, and emergency response continue to be explored. We've had a fair amount of discussion already about the new Center for Forecasting and Outbreak Analytics. And so this particular issue 3 is an opportunity where some of those concerns or some of those opportunities can be voiced. Next slide. So the new CFA was stood up in August of 2021. And it really starts taking these capabilities to the next level. The work of DMI underpins this work and will be necessary for its success. The slide here just provides the proposed value of this center during the outbreak of a novel pathogen, with those 3 areas that are listed as the priorities for the Center for Forecasting and Outbreak Analytics of predict, inform, and innovate. Those include parameter estimates, scenario models and forecasts, targeted studies, responsive analytics, etc. So we look forward to hearing from you on the next slide, which is the question that we pose: how should CDC prioritize advancement of forecasting and analytic efforts to integrate public health activities and address health equity? So it's a targeted question within the context of a lot that CFA will be addressing. Next slide. Our 4th issue is with workforce. CDC is supporting modernization of the public health workforce as a major activity to ensure sufficient capacities and capabilities across the stilts and at CDC. If you could go to the next slide. So in line with our DMI priorities, we've been taking a variety of innovative approaches to build a state-of-the-art workforce. We are recruiting and building through fellowships, infrastructure grant that has $3 billion that will be available over 3 to 5 years, where those are not specifically just for data scientists and for DMI related activities, but for the whole of the public health workforce. But clearly, those data scientists and related needs are a strong component of that workforce. Also, the Public Health AmeriCorps, which will be providing over $65 million in awards to 82 grantees across 32 states. We're offering training at CDC through data science upskilling, through data science teams, and through our Applied Public Health Informatics Fellowship that builds informatics, data science, and laboratory capacity at state and local health departments. And then forecasting our future needs through the Public Health Workforce Research Center, which will inform health workforce educators, planners, policymakers, and audiences interested in public health workforce, and working closely with HRSA's National Center for Health Workforce Analysis. Next slide. The question we have here is, how can CDC work with partners to support the public health enterprise by increasing access to data science and information technology skill sets and staff from academia and the private sector, and addressing barriers to hiring and retaining experts in these fields? The next slide is issue number 5, breaking down silos. As I touched on earlier, the complicated and disconnected web of public health data systems which create data management and reporting burdens on public health staff are in large part a result of siloed programmatic activities which have been propagated over time by categorical approaches to funding. Next slide. So when you hear about different DMI projects, you may notice that they are led by or funded through a specific center. Because of the way we have traditionally been funded in the past, each of our centers holds long-standing expertise in specific areas or with specific systems, and we need to recognize and tap into that knowledge. At the same time, we need to build bridges. For example, in our first priority, which is to build the right foundation, we have our Office of the Chief Information Officer at CDC leading the development of our cloud-based enterprise data analytics and visualization platform. And we have our Center for Surveillance, Epidemiology, and Laboratory Services and the National Center for Health Statistics leading much of the work around our core surveillance systems. So at the same time, our National Center for Immunization and Respiratory Diseases is leading the way on our immunization system modernization. So as we recognize the expertise, we also need to recognize that the, quote, old way of working no longer serves us as an agency at an enterprise level. Our data modernization initiative implementation approach is applying mechanisms that will bring us out of our silos. We have begun forming cross-agency teams that will allow us to find shared solutions to shared problems. We've set up a structure that's guided by our DMI priorities and objectives and is not dictated or limited by center or even who's funding and who is not. So this, we hope, will ensure we're serving the greater needs of the agency and that our investments are available and reusable across the enterprise. So we want to unlock the answers to large public health challenges by using all the data we can across program areas. This is a big shift from how we've done things before that will have really meaningful implications for what we're able to do in the future. Next slide. So the question here is, for the next phase of DMI, what agency-wide activities would most benefit from a coordinated all of CDC approach? What efforts could ensure long-term sustainability and success in achieving modernization and supporting advancement of agency priorities like climate change and health equity? Next slide, I believe, is the last of the issues. There are a lot of them, but they are all important. The last is assuring sustainability. Implementing and maintaining a modern public health data ecosystem will require all levels of public health to rethink the business policies, practices, and procedures of public health agencies to support more nimble approaches to information technology and sustainability of data infrastructure. Next slide. This is a, next slide. Yeah, this is a bit of a busy slide, but sustainability is critical. And the jurisdictions repeatedly caution us that their hands are often tied when support is limited to annual funding. And to address this, we've included a component in the new public health infrastructure grant being managed out of the Center for Surveillance, Epi, and Lab Services that could fund data modernization activities for a 5-year period. If funding were to become available for the DMI portion of the grant program, our still partners would have more time over which to plan and implement modernization activities. They would have more flexibility in how to use those funds compared to the current cooperative agreement mechanisms. And the current mechanism that we're using is the Epi and Lab Capacity Grant Program or cooperative agreement, which delivered $200 million in direct DMI funding for jurisdictions in FY21. That $200 million was focused on supporting foundational data modernization activities, on accelerating modernization of the National Vital Statistics System, and in leveraging the incredible progress made over the last 2 years by scaling up electronic case reporting to include all notifiable conditions. A big task, but one for which we are prioritizing through the funding that we're providing. Through ELC, we've also increased access to technical experts and consultants. We've also provided funding through a variety of mechanisms to national partners such as CSTE, ASCO, Public Health Informatics Institute, and others to strengthen learning communities, communities of practice, and targeted workshops. By putting the new infrastructure grant mechanism in place now, we have opened the door for more flexibility and sustainability as our state and local partners build on this progress. So next slide. So the final question is, how can CDC work with partners to address barriers related to funding mechanisms, procurement, and program delivery? What mechanisms for assuring sustainability of modernized systems need to be developed and implemented? Next slide. And the final slide is the Data and Surveillance Workgroup has some specific activities, participating in sessions to consider and address the guiding questions, drafting a report of the findings, observations, and outcomes, receiving ad hoc presentations. Those could be from the CDC DMI leadership team or others at CDC to review the aims, content, and underlying assumptions of the DMI strategy. They could come from CDC programs on evidence-based approaches, tools, and what's driving successful implementation of data modernization activities, and on initiatives, both internal and external, that will impact DMI outcomes. So reviewing CDC's DMI implementation, outcomes, progress, and metrics is another important thing to provide feedback to the ACD and providing updates also to the advisory committee at each meeting. So with that, I believe I'm going to hand back over to Dave Fleming.
Wow, thanks, Dan. That was incredible. If the rest of the group is like me, I kind of feel like I need a break, but we'll do that after the end of this session. Thanks so much for your leadership. And clearly many issues here, important ones, and the work groups clearly has its job cut out. I'd like to open up the floor for questions. Questions and then comments also on the terms of reference. Dan, the committee was sent the terms of reference in advance, and so we can discuss that as well. And first up, I see Rhonda.
Hi, good morning. And that was probably one of the most comprehensive presentations that I will have of the day. That was a 4 coffee cup presentation. I know that what you presented requires a lot of work. I just want to make sure that we are including in the non-traditional public health partners. During H1N1 and this current pandemic, we've learned a lot about how to use non-traditional public health data to kind of identify where there are hotspots developing, where there may be a problem emerging. And we also discovered new ways of actually using the information coming from the public health side to the healthcare side. So I really hope that on this committee, on the subgroup that we're going to have, you're including a lot of people who had the work of being on the ground, right? And not just in the hospital setting, that's important, hospital and ED, but also the people who are in primary care, who saw things in local communities, people who have pharmacy data real time, right? Because sometimes people get prescribed a lot of antivirals without a test, right? And sometimes that's the first clue in some of the local or rural communities. I'm just saying, non-traditional partners, please make sure that we include it. And I liked your questions. I think I'm still in the mode. And I know I'm taking a lot of your time, but I'm still in the mode of thinking one of the questions needs to be, how do we leverage all these diverse information sets and data to be faster, better, stronger before the next wave or the next pandemic occurs?
Great, appreciate that. And I think that focus on what we call non-traditional data is really important. It may not have come out in the slides, but I do think that is an important thing for us to recognize. There's so much that we need to do with the existing traditional public health data, but there are other data sources clearly that have been used through the pandemic that really provide additional information. They also can provide significant sources of social determinants of health information, health equity data. Those are things that we absolutely need to consider. And I think we here at CDC have been considering those as a part of the data sources, but identifying how to call that out here, I think would be very helpful.
Great issues. Thanks, Rhonda and Dan. Josh, you're up.
Thank you so much. And I really appreciate the presentation and the scale of the challenge. I think our comments about how dense your presentation was, necessarily because of all the different data topics, led me to think about my time on the HIT Policy Advisory Committee for ONC, where I spent a couple of years, where you could sit in a meeting sometimes and just hear about, metrics galore for what EHRs were gonna, exchange, but not really understand why, like what the purpose was. And I wonder, in my experiences with data, there's always people who are like dragging their feet at whatever level. It's just a very abstract concept until it really matters for health. And there's a real explanation for what you can do with data. And I wonder, alongside your sort of technical goals, do you have a set of goals for what the public health system can do? People should be able to get their immunization records wherever they show up, or outbreaks of asthma should be able to be identified within a week. What are the things that are motivating this, that could be the functionality that inspires people to do all this work underneath the surface?
Yeah, I think you're getting at some of that was presented, I think, in the original presentation that gets at some of that. You are getting at identification of objectives and key results to make sure that we have measurable outcomes. And so some of those are listed in the strategic implementation plan, but I really appreciate your comments. We are going through and further defining a lot of those objectives and key results. And as we update the implementation strategy, that will be, those will be present there. But your point is that, can we have clear objectives that could be presented rather than the dense presentation? And I think for this discussion here on those specific questions, I think we erred on the side of density, but happy to get back with you on those higher level objectives and key results.
Thanks,
Thank you.
Thanks, Dan. Yeah, we need the density, but the high level results are important to both ends. You're up.
And great work going through a lot of material. I know you've thought of it, but you mentioned the words all of CDC approach. And I know you've thought of, what about beyond CDC to CMS, FDA, and others, actually even outside of HHS in government as well? And what work has been done around those approaches toward public health?
Yes, so as a part of the data modernization initiative, most of our efforts have been within HHS, working closely now with CMS on some of the capabilities that they have that might be leveraged in order to improve data reporting and data gathering. We've been working very closely with the Office of the National Coordinator and been using their capabilities to help with electronic health records and certification of systems. We have had some discussions with DoD, some with VA, some actual activities with them through the pandemic, utilizing some of their data sources for some of the pandemic work. We have not tried to have a whole of government approach here. I think we have been focused mostly on addressing those issues that are within the CDC and still partner ecosystem because of the near-term need to focus on those. There are a lot of possibilities of utilizing other data sources and data systems, and we would love to have your input on exactly how best to utilize those.
Great. Octavio.
Yeah, Dan, a great presentation. I'm going to stand up to what I already mentioned to Dr. Walensky, which is a recommendation to consider for your work group as you're standing up, someone who's really their skill set and expertise is about communication. I think good communication, effective communication, evidence-based communication is truly a skill, as we all know. We all think we can communicate. We can all talk. We're not necessarily communicating. And the reason I bring it up is because the work you're doing, I think, is so key, and there's going to be a lot of intergovernmental. And I think having someone who has that skill set and understands the difference between just regular communication, health communication, public health communication, they all have nuances, can really also help down and break down the silos that I know you're going to have to also deal with, especially when it comes to data. So just wanted to put that out there for you and your work group to consider.
So that's great. I mean, the issues are technological, policy, change management. They are many. And so I appreciate that. And so part of that communication is also identifying those key priority activities that we are focused on and then communicating the work that's happening on those focused activities.
Thanks. And let me take the opportunity to mention something here. And we're also going to talk about it briefly when we talk about the laboratory working group. As you know, the working groups are constituted of ACD members, but then supplemented with non-ACD members as well. We've been working hard, CDC has been working hard on this. We use a federal registered notice process to solicit outside applications for folks to join the work group. That notice for both of these work groups will be going out on the 4th, so in a couple of days with a 10-day turnaround time. Maybe John, someone can put into the chat the link just so that people can see what those notices look like. But would really encourage, first off, all members of the ACD, to the extent that you know of people who would provide value to either this work group in data and surveillance, and we'll get to it in the laboratory work group as well, to encourage those individuals to apply. And don't want to put either Julie or Nirav on the spot, but I know that you've done a little bit of thinking already on the nature of expertise that would be important to have in order for the work group to be functional. I'm wondering if one or the other of you would just want to briefly mention some of the criteria that we might be looking for in these outside applicants.
Let me start, and maybe Julie can pick it up from there. Certainly the expertise in state and local, active experience in state and local data and issues is highest on the list in terms of urgent and important needs. But there are many other issues. We need folks who are lawyers who know about data privacy. We need subject matter experts who know about cybersecurity and many others. And I think that Dan's done a nice job of showing some of the things that we need, some of the skill sets we need. And already we're starting to draw a wide umbrella full of people who we might reach out to actively, because it is a very quick turnaround time. For, I believe 10 days, we need to have all the nominations in. So stay tuned. Julie?
Yeah, I'll just agree with what Nirav has said already, and also add that I think we're looking at healthcare systems as well as electronic health record systems, because we recognize the value of those systems and the data that they have in terms of informing public health and really coordinating with them carefully. I think the other thing we want to make sure is we're keeping an eye on equity. So looking for people who have expertise in data and data health systems as a health public health data systems as it relates to equity as well. So we have a list already, a spreadsheet, and Mirav and I are adding more names to it. Would welcome your suggestions and your solicitation of people to apply. And then we're also looking for ACD members that are willing to be joining the group as well.
Thanks so much. We'll go back to the questions. Ada.
Thank you. And thank you for that great presentation. I have two sort of questions that are related to each other. And one is concerning the use of these electronic medical records, which have become really a driving force in medicine and are a great source of data. And it sounds like that was your intention, was to try to loop these in, which is a great idea. And I was just wondering how to do that. This is probably not even an appropriate question for this stage, but these systems really appear to have been developed more as billing tools than as actual medical communication tools, or certainly surveillance systems. And so the systems themselves seem to sort of work against this. And in addition, there are all laws and issues related to privacy, but they would be a great source of data. And so I really support your trying to loop them in. And one suggestion I have is for people on this committee, if you're looking for members, are representatives from some of the major electronic medical records companies, especially Epic and perhaps Cerner, really to try to help with this. The next question is related, and that is, I was trying to understand the central hosting versus the local versus the hybrid. Does the central hosting, you may have said this, but I just missed it. Would that mean that the data could go simultaneously to the state or the state and local and to CDC at the same time, if it's centrally hosted? If so, that sounded like a good idea to me, because it would be much faster and actually might, while the state and local systems, would get the data, it sounds as if they also could potentially have less work, which they should like. Is my understanding correct?
Correct. And so there are currently in place solutions that we have for electronic case reporting, where those reports from an electronic health record go to one place and they are made then available to the state and territorial partners. And so that model is one in which it could be expanded in order to have some information that is of national utility be available through that mechanism. That the way we would do that would be through data use agreements and other approaches. But so the technological model is already being used for electronic case reporting. And then there's also the model that is used for syndromic reporting, where 71% of all emergency departments in the United States are currently able to be represented in that information is captured in a place where state health departments have access to their data. And there are capabilities whereby we can, at a federal level, certainly for COVID, be able to see what's happening at the different emergency departments. So those technologies are in place. It's a matter of policies and other things that have to be figured out. And so what we would like is the input from the group on how best to enter into that activity for a broader part of the public health ecosystem and not just those two examples. With regard to your electronic health record first question, there is a difference between claims data and the data that is captured in the electronic health record, which is used for medical encounters. The case reporting data that we're getting currently is coming directly from the electronic health records, but does include information about the patients, the demographics, the encounter information, the medical, the therapeutics listing, vaccines, et cetera. That data that is collected as a part of that encounter for a reportable event is what's being captured and sent to the state health departments. So again, the capability to use the electronic health records, which is not just hospitals, it's anywhere where a health record is used. And in fact, most of the facilities reporting now are not hospitals, they're actually doctors' offices and other settings. So the capability is there. The DMI is allowing for that to increase in its use. We're working with CMS to make sure that there are incentives or conditions that make it such that we will use more of that data. So we're in a good place of knowing how to capture that data. We just need to know how to do that for multiple different public health data requirements. And so that's where I think the task of us figuring that out will be occurring over the next few years. But also we will be working continuing to increase the amount of case reporting, notifiable case reporting that's already underway.
Well, kudos to you, because many researchers have been brought to the ground trying to deal with Epic and doing research with the DMRs.
We're also in communication with vendors as well as a part of our public-private partnership through CDC Foundation.
Thanks.
Great, thanks, Dan. I see 4 more questions. Over to Lynn Coleman.
Thank you. Hi. That was a great presentation, and I just wanted to say how much I appreciate how thoroughly the agency is mapping out this effort. I think that I'm, along the same lines of the prior discussion, there are a lot of data outside of CDC that CDC is going to need to consider. And I think the EHRs are among those. The EHRs don't collect a lot of the information about social determinants of health that they could collect, and that would make that system better from the standpoint of addressing public health. And I think if you're working with the vendors, that's very helpful, because there's certainly a lot of room for improvement there. But there are other data, there are environmental data and other data that are not in the CDC systems, but that CDC uses that I'm sure will be considered as well. I think that's even during COVID, the data about travel and the amount of time that people were spending in their cars every day was important, right? And so it's not all going to be in the healthcare system. And I hope that the group can think broadly about that.
Great, really agree totally with the addition of those other data sources.
Daniel.
All right, sure. Thank you so much. So I understand from your presentation that you're looking for innovative and equitable approaches and practices, and you've identified the 6 main areas that you all will be focusing on. But I'm curious as to whether the inequities in digital health and related technology design and application, as well as the digital and technological conditions that influence health inequities, is something that you all are going to be specifically looking at within those 6 priority areas, or within one in particular.
These 6 questions are the ones that we would pose to the group. The issue you're getting at, I think, is the problems with inequities that may be introduced through the technologies themselves. And so as a part of the Center for Forecasting and Outbreak Analytics, there is funding that has been provided to academic partners to actually look at inherent bias in algorithms, in predictive analytics, and other tools that are used. I think many have heard about the means by which you can teach these systems in order to give us predictions and do forecasts, but the information that you provide so that they can do that forecasting often may not be equitable, may not be describing the broader population. And so those kinds of things, I think, are being looked at through the CFA's work with their academic partners. We at the agency are looking at ways to improve health equity through collection of information, development of standards in order to get that health equity data. And then to the earlier questions about different sources of data, looking to see how can we connect those different data sources to the programs so that they can link data and understand the context around a case, so that they can infer the social determinants of health and other factors that may be available in other data sources to that case. And so those kinds of tools we're looking at to help locals and states with the work that they do to try and get at that. But to your point about inherent biases and the digital equity issues, we are not, we don't have a specific focus within DMI right now on digital equity, and that is availability of internet capability to have the technology available. But that's something that we'd love to hear from you about if that's an important thing for us to be working on.
Fantastic. Thank you, Doc.
Josh.
I had just had one quick question as we were thinking about other sources of data. Have you, given how much data is at CMS, is part of this sort of helping other agencies kind of package their data and make it more available for state and local public health or to CDC? I mean, that's not exactly building the pipes of a new system, but they, have so much information, which often is, hard for state and local health departments to access. So in other words, do you see this as primarily about the data resources that CDC is engaged in building, or can this be a conduit for other data to the public health system?
I totally agree. And I think we have to really push against the concept of one-way data flow. And that we really are not trying to just speed up the one-way data flow. I think it really is decreasing the friction of data to getting to those that need to do the work, state and locals, and then for those that need that national view of things. But through a number of processes that we have learned through COVID, there's a real capability to get data back to the states and locals that is aggregated, that it can be very meaningful information for jurisdictions. So getting that data back is critical. To your point, are there data sources that are not captured through any other kind of traditional public health route, like CMS data, that could be made available to state and territorial and local partners? The answer is yes, there could be. I think Nirav Shah has indicated that's an area of interest to him, is that looking at those authorities for the sharing of that CMS information, and is there ways to take that data, and you could call it packaging or giving access to certain parts of it that are targeted to jurisdictions so that they have ready access to data that may be very helpful for them for hypertension, diabetes, and other interventions. So we would love to think through those things as well as a part of the, not just data one way, but really a flow of data in both directions, a bidirectional flow.
Thanks, Dan. In a moment, we will need to move on to the terms of reference and in particular a vote, which we'll talk about. But Jill, last question before then.
Just very quickly, thank you, Dan. So Nirav brought up the need for attorneys, lawyers on the work group to deal with patient privacy. And an issue that we have struggled with for many years, as you know, is what metadata needs to go with what, say, lab data. How much personal data needs to go with the sequence. An issue that's coming up is the rapid tests, the over-the-counter rapid tests, and what data is useful for those screening and surveillance examples. What's the mechanism you're going to use to figure that out?
So there's a lot there. Historically, laboratory data is it's a component of what the public health establishment needs in order to become a case. It's sort of the atom that makes the molecule of a case. And so that laboratory data, from our standpoint in public health, that's where we've moved forward the most. And the collection of that data often comes from laboratory information management systems, from reference laboratories, et cetera, places that are performing the test that are not providing the care to those patients. And so we end up in a situation where there's a lot of lab data that we get, which does not have a lot of demographic data to it. And so there may be ways that the data that are coming from those that have to report it, like a reference laboratory, could be augmented through other means to provide some of that data that can give more information about the demographics, race, ethnicity, et cetera. There are possibilities that are now being explored in the standards development space, whereby a laboratory that is reporting may be able to do an automatic query of that reporter, the person or the one that ordered the test, and gather more information on it. So there are a number of different possibilities there. It's not an easy thing to try and address as a low-hanging fruit, but it is an important thing because we definitely recognize that laboratory data is probably one of the most critical components of information that we need. So as a part of our DMI consortium, we have identified laboratory test ordering and results as one of our primary use cases to try and identify ways to fix it.
Thank you.
Thanks, Dan. Rhonda, I see you raise your hand.
No question. I just wanted to say thank you, Dan. I can imagine all the work that the team put together for you to do this incredible presentation. You can hear the passion in our voices and our questions. We're going to be good friends, I can tell already. Lots to do, lots of things to connect, and thank you.
Great. Thank you.
Well said, well said. So we do, for the terms of reference, need to take an official vote of the committee to approve them. So far, I have not heard anything but general agreement. I'm going to give Nirav and Julie just a brief opportunity to say, express their comfort level or not with the terms of reference, and then presumably we will proceed with a vote, which will involve a motion and a second, and then a vote by all the members. So Julie and Nirav, your comfort level with the TORs.
I'm very comfortable with it. I had a chance to review it several times and was lucky to speak with Dan in detail as well in advance of this meeting. So I think with thoughtful selection of the right additional members to the group, we will be able to do a lot.
Thank you.
Yes, I agree with Nirav that I've also had a chance to review the terms of reference a couple of times and had conversations with Dan and with John as well previously and feel very comfortable with it. I really am impressed with the way it's approached in terms of covering both the quality of the data that's coming in as well as how the infrastructure is necessary to use the data in meaningful ways. And so I'm excited to see about the way we can engage and support this work moving forward. I also appreciate the focus on standardization and yet also flexibility that's built into various elements of the plan. And so feel strongly that the terms of reference really outline appropriate roles for us to play. So would be comfortable moving forward.
Thanks, Julie. With that, I will accept a motion for accepting the terms of reference for the data and surveillance work group. Do I have is there a second?
Second.
Second.
Any further discussion? If not, could all members in favor of adopting the terms of reference either raise your hand? Oh, I'm sorry, Crystal, are you?
No, I was raising my hand to vote for
Okay.
it. Sorry.
No, yeah, please raise your hand either on the screen or you can just receive. Oh, perfect. I am also in favor of this. Are there any opposed? Abstentions? Great. The terms of reference pass. Congratulations. Thanks so much to the co-chairs and a special thanks to Dan Jernigan for leading us through that discussion. And we're off and running on this one. And with that, we now have earned our break. And so we will take a break until, John, just correct me, we want to go till 15 past the hour, right?
If possible, we might go only for a half an hour. So that would be 10 minutes after the hour.
Okay, well, we will do that. I'm assuming that Barbara Mann will be able to make it then. So we are on a break until 10 minutes after the hour. That's 10:10 Pacific time, 1:10 Eastern Daylight Time. We'll see you back then. Thanks so much, everybody.
Million mark for deaths, two rather somber milestones. And of course, both of them are underestimates and more so in some areas of the world than in others. Next slide, please. I'm going to focus on the situation here in the US. And as I think most, if not all of you know and recall, back in February, CDC rolled out a new metric, which is called the COVID-19 community levels. And this is a measure of the impact COVID-19 is having on communities. And is intended to be the link to mitigation recommendations. So I wanted to spend a minute on that. The COVID community levels are based on hospitalization rates and the proportion of staffed hospital beds that are filled with COVID patients, as well as on case incidents. And they reflect they reflect that at this point in the pandemic, it's pretty clear that SARS-CoV-2 is going to continue to circulate. And so our metrics that link to action really need to be focused and to reflect the goals of preventing medically significant illness, protecting the most vulnerable, and minimizing stress on our healthcare system. Before I get into the actual data, I wanted to make a few other points. So first, the COVID community levels have not changed our surveillance system. We continue to collect and report daily reports of cases, hospitalizations, deaths, et cetera, variants. None of that has changed. Secondly, the COVID community levels are built on hospitalizations. We selected hospitalizations as the foundation because hospitalization data are available for every county or health service area, which includes every county in the nation, and because hospitalizations correlate with the outcomes of public health significance. So not just hospitalizations, but also deaths, ICU admissions, medically attended outpatient illnesses, loss of work and school time, even post-COVID conditions, which are strongly correlated with severity of illness. So it's not that hospitalizations are all that matter, it's that they are a universally available measure that correlates with all of the outcomes of public health significance. Also, I wanted to mention that the framework in which we encourage jurisdictions to think about their COVID community levels also includes their vaccination coverage, critically important, and other local information that may be available. So some localities have access to information about wastewater surveillance or emergency department syndromic surveillance, just to mention a couple. And so for localities that do have those information, those kinds of information, the COVID community level can add, but it's certainly not intended to replace. We also continue to closely monitor leading indicators of potential new surges, and I'll show you some of those leading indicators in a minute. So on this map, we see the COVID-19 community levels. This is actually from April 21st, a little bit more than a week ago. Low is green, medium is yellow, high is orange. And as you can see, we were in low for most of the country. On the 28th, last week, there was a bit more yellow and orange, but still last week, more than 98% of the population was a low or medium level. As you're all aware, cases have been steadily increasing in recent weeks, with some localized increases in hospitalizations as well. And I'll go into this a bit more in the next slide. So could we go to the next slide, please? So this Sankey graph it shows the transitions between low, medium, and high levels for the whole country over the past 5 weeks. So each of the vertical bars is the state that the country was in during 1 week. And then you see the changes in those ribbons that move over the top from 1 week to the next. So in sum, what you see here is that most of the country has been at a low level for this 5-week period. But in recent weeks, we're seeing some, so far, relatively small increases in the number of countries at a high or medium level. And we continue to follow these transitions closely and to work with jurisdictions on both on the data. These are a new metric, and so there have been some questions that have come out that we're working closely with jurisdictions to try to answer, and also on sort of implementation questions. Next slide, please. So in the next few slides, I'll go deeper into our current epidemiology, and here you see the cases shown in purple, and you see they're currently, this is over the entire pandemic. So currently cases are at quite a low level, although you do see some recent increase in the last few weeks. Again, this is the graph from April 24th. The updated graph continues with steady but not steep increases. At the bottom figure in orange shows hospital admissions. So this is new admissions, not prevalent admissions. And we are at some of the lowest hospitalization rates that we've seen since the beginning of the pandemic. Again, slow increases in recent weeks that we are following closely. Next slide, please. In terms of deaths, they have been thankfully decreasing for several months. We were at a daily average of 314 when the slide was made. We're now down to 308. And as of last night, we're continuing to decrease. Next slide, please. Wastewater surveillance has been in the news quite a lot recently. This is a really promising approach, but it is a new approach. And we're still learning how to best take advantage of it for COVID-19. At the same time that across the agency, we're thinking about how else, for what other pathogens it could be or conditions it could be useful. This is the map from April 24th with dots that are color-coded to match the percentage of increase or decrease. These are very local measures. They're just in a single sewer shed for each dot. And you can see that there's a lot of variation across the country. And one of the things we're learning about is that this variation can be due to things that have nothing to do with disease rates, but things like rainfall and whether rainfall goes into the material that heads to the sewage treatment plant. It can also be due to how close a case lives to the sewage treatment facility. Wastewater surveillance is a leading indicator. We've consistently seen increases of about 4 to 6 days before there are increases in cases. And wastewater also has the potential to identify a variant, a known variant. You can't discover a new variant with wastewater, but they can identify a known variant before case surveillance does. Just here, I'll just point out that we have been seeing decreases in New York State and are hoping that this is a leading indicator of a decrease in cases in New York State, which has really been the state that has had the greatest increases and the highest community levels over the last month or so. Also, I'll point out that in some other states, you see very mixed pictures with areas of increase and areas of decrease. Next slide, please. In terms of variants that are circulating, we are currently seeing all Omicron in the United States. This is the nowcast figure where each vertical bar shows the strain distribution for 1 week. So this goes back to mid-January and up to last week or the week before last. We are seeing the subvariant of Omicron, BA2, comprising an increasing percentage of what was, across most of this time, a decreasing number of cases. So BA2 is the sort of light lavender pink color, and you can see that it's an increasing percentage. Now, just in recent weeks, we're seeing a subvariant of BA2. This is BA2.12.1, making up an increasing proportion of the cases. It was first seen around New York. It's shown in this figure in the sort of salmon red color at the bottom, but it is now present in all regions of the United States. Not shown on this graph are BA.4 and BA.5, which you've seen in the press, causing cases in South Africa, in India. We have seen a handful of BA.4 and BA.5 in the US, but just a handful, starting for each of them first at the end of March. So they have not been increasing rapidly here. We continue to monitor this carefully. Next slide, please. In terms of vaccination, last week we passed the 500 million doses administered milestone here in the US. which is not everything we would like to achieve, but I do think is worth pausing to celebrate. 500 million doses is a lot of doses of vaccine and represents a huge amount of really good work to get those doses out, even while it's not the end goal, and there is still a lot of work to be done. There's, as you see in the map here, a lot of geographic variability in vaccine uptake. This is not news to any of you. Most of the doses that are being administered now are second boosters. And on the next slide, I'll go a bit deeper on boosters and then subsequently on second boosters. So this first graph on the left with the sideways histogram shows receipt of boosters by racial and ethnic category among people who are eligible for a booster. Excuse me. And so you see in the third row down that the highest rate of booster receipt in people who are eligible for a booster is in the Asian non-Hispanic group. And then in the top row, you see that the lowest is in the Hispanic and Latino group. The figure on the right shows booster receipt by age group over time. And there's really a remarkable range here from over 70% in the 75 and older group, with 65 to 74 right behind them. Those are the purple and pink dashed lines at the top, to under 30% in the 12 to 17-year-old group. Next slide, please. And I wanted to say a word about second boosters. At the end of March, FDA authorized a second booster dose of either the Pfizer or Moderna COVID vaccine for people over 50, or for those over 12 with moderate or severe immunocompromise who had received their first booster at least 4 months ago. The CDC director and ACIP both endorsed the option for these groups, and also for people who've received 2 doses of the Johnson & Johnson vaccine at least 4 months ago. Last week, we posted some considerations that people who are eligible for a second booster can use to decide whether to get that second booster now, or whether to wait for later in the summer or a potential booster campaign in the fall. Next slide, please. So that's a brief update on the pandemic, and now I'll just quickly turn to some current priorities and recent achievements of the response. Next slide, please. So we continue to prioritize health equity. We have, in the last couple of months, had an increased emphasis on persons with disabilities, and we've established a disability officer position within the response unit of the Chief Health Equity Officer, which John is currently leading. Some of the work here has related to strengthening ties and addressing concerns of people with disabilities and people with immunocompromising conditions, and ensuring involvement from these communities in planning and responding to new developments, such as issues around travel mask mandates. We're also working with other governmental departments that are in the lead on therapeutics to promote accessibility of therapeutics to marginalized communities, and whether disabled or immunocompromised or not. We're also reviewing the impact of and lessons from the grants that we made earlier in the pandemic that focus on communities of color, and planning to ensure that equity remains a priority and remains enacted as a priority, both inside the COVID-19 response and in CDC's centers, and as activities are moved to their programmatic homes. So this is an area where we would really appreciate advice that you on the committee might be able to offer to us as we move forward into the next phase of COVID. Next slide, please. Related, we are working on and have recently launched some tools and materials to help communicate with the public about their COVID-19 risk, and launching materials to help people, especially those who are at a higher risk, to better understand their risk of getting seriously ill and the actions that they can take to protect themselves. So there's a planned Know Your Risk tool and communications that are available and also in development for communication around treatment availability. And we're working on this in collaboration with other governmental departments. Next slide, please. We continue to work to sustain the use of COVID-19 vaccines, which is just the critical foundation to protect the health of individuals and communities, and recommendations are still rapidly changing. So this is still a focus of a great deal of work. We're supporting the uptake of second boosters, working to improve equitable access both domestically and globally, supporting efforts for all eligible individuals to be up to date on their vaccines, and importantly, preparing for vaccines for children under 5 years old. And here too, very interested in your perspectives on any of these aspects of vaccination, the vaccination program, both domestically and globally. And then next slide, please. Finally, this is my last slide. We're working on the response activity transition planning that you've already heard about. At this point, CDC and really all of public health needs to be incorporating COVID-19 into routine public health practice and planning for the long-term sustainment of key public health activities. So we're working to transition the majority of programmatic and scientific response activities to long-term homes within the agency. And important that we will be continuing with an incident management structure that reports directly to the CDC director. It will be streamlined, but it will remain activated. And overall, our goal is that this transition should be seamless from the point of view of the public, CDC's public health partners, jurisdictions, et cetera. So with that, that was what I wanted to tell you about, and I'm glad to hear your thoughts and advice, and to take any questions that you might have.
Great, thanks so much, Barbara, for that excellent presentation. I learned a lot, and I'm going to open it to the floor to ACD members for questions or comments on the issue that you had raised. I know that you have a hard stop at 45 past the hour, so we'll make sure to get out of you by then, get you out by then. And first, over to Julie.
Hey, Barbara, thank you so much for your service and for playing this role for so long. You've been doing a great job. I wanted to just talk about a couple of things that I'm worried about, and I think it relates to this, the therapeutics and also vaccine work, because as we're looking forward, I was excited to see the distribution or the plans for the Paxlovid support. And then at the same time, I was worried about how we're going to get this information into the hands of the communities that have been so disproportionately impacted throughout the pandemic. Because I think, that for people who have access to the information, they know that Paxlovid is a really good option, but you have to get it within a short period of time after diagnosis. And I'm just concerned that some of these communities of color, low-income communities, rural communities might not have that information. So really wanting to encourage CDC to really ramp up and build support to really get that information into communities. And at the same time, thinking about leveraging that same kind of community-based effort to support the childhood vaccines when the childhood vaccines are available. Because we know we're on the brink of having some under 5 vaccines available, and that's a very exciting opportunity. And yet what I don't want to see is the disparities that we have seen in the past with childhood vaccines and adult vaccines play out again with this effort. So I'm hoping that CDC will put the effort and resources into the support of community organizations, that we're really able to get the information out into communities as it related to adult vaccines, to do the same for both the therapeutics as well as for the childhood vaccines. Because I think those efforts would really were beneficial and could be beneficial in these situations as well.
Yeah, thanks for the comment. And I would very much agree with both points that you made. We are working with the ASPR on options for, first of all, expanding access to the Test to Treat program, which it's a great idea that to have the ability to just go into a pharmacy with, your home test, or to get tested there and to be just then get a prescription right away. But we also know that the pharmacies that have prescribers tend to be in wealthier, lower SVI communities. And so we've been actively working with the Assistant Secretary for Preparedness and Response to work to evaluate how equitably the distribution of the antivirals has been so far, and to explore ways of expanding access. So that's just simply access. You also were talking about communication, and very much agree with you there as well. We're working with the ASPR, with the Surgeon General on communications around oral antivirals. I think you're right. There's a lot more that needs to be done, and we share the sense of urgency to get that information out there. In terms of the vaccines, the under 5 age group is a little different from the others in like where they will be vaccinated, right? So I think you're a pediatrician. Kids under 2 aren't going to be getting vaccinated in pharmacies very much, if at all, we expect. And so it's even more than for the older children. It's going to be very important for providers of primary care for children to be to have all the information they need, and all the operational support they need to be able to administer these vaccines. And a number of organizations, American Academy of Family Practice, American Academy of Pediatrics, and others, we're working with them to plan. Dr. Levine, the Assistant Secretary for Health, is very concerned about these pediatric issues as well. So I am hopeful that we will have a equitable rollout. I also see a lot of barriers, as I think you do, and anticipating lots of questions from parents.
Thanks, Barbara. One thing I'll just add is that I, as a pediatrician, I am completely appreciative of the role that healthcare providers play in the administration of vaccine to young children. And yet I also am a firm believer that there's a need to complement that through educational efforts through the community as well, to make sure that people are getting the messages from other trusted sources of information as well. So I feel like that would be important to support. And also, I'll add this on tangentially, as you're thinking about integration of COVID vaccine back into the rest of CDC efforts, when I look at the childhood vaccine coverage levels and what's happened as a result of COVID, feeling like those kinds of efforts should be coordinated to really, as you're focusing on COVID vaccine for children less than 5, also addressing the other routinely recommended childhood vaccines that have coverage levels have really been dropping. So thank you for all you're doing.
It's a really good point. Thank you.
Yeah, thanks for raising that, Julie. Over to you, Crystal.
Yes, thank you so much, Barbara. And I appreciate Dr. Morita raising those issues. They were top of mind for me as well. I had 2 other quick questions, though. One, when you talked about the, we're seeing an increase in the percentage of the B.2A.12.1 variant. Are we seeing that in hospitalizations as well? Is it a growing percentage of, hospitalizations, or right now are we only seeing it in the community? And then my second question is about vaccination. And one of the things that I'm hearing is a lot of confusion out there about what is the difference, if any, between eligible and recommended. So if, once CDC says that, a group is eligible for a booster, does that actually mean the same thing as it's recommended that they get a booster?
Yeah, those are 2 very good questions. In terms of BA2.12.1, so I think probably there's two answers. There's two components of the answer to that question. Our variant surveillance is based on strains received at laboratories, and that isn't necessarily linked to clinical information. So we do know that we have seen a somewhat of an increase in hospitalizations, less than the increase in cases in recent weeks, and we're following that closely. We separately, we and others are working on studies to try to look at the severity of BA2.12.1 in populations where there's the ability to gather the data to control for confounders and to really look in a robust way at severity. To date, there is no information suggesting that BA2.12.1 is more severe than the disease caused by other variants. It may be a little bit more transmissible, but there's no indication at this point of an increase in severity. In terms of, I'm sorry, I should have made a note. You were talking about,
the eligibility,
recommendation versus eligibility. Yeah, no, this has been confusing, and we know even before COVID that vaccine recommendations that are not like clear cut, you should, are always difficult for providers and for for the public. So the first booster recommendation is a should, right? If you have had a complete primary series and the relevant amount of time has passed, 4 months, then you are eligible for a booster and you should get a booster. That's the recommendation. The second booster is a may. So if 4 months has passed since your first booster and you are over 50 or over 12 and moderately or severely immunocompromised, or had 2 Johnson & Johnson shots, you are eligible and may get a second booster. Those considerations that I mentioned are an attempt to help people work through, like, well, I may, but what am I going to decide to do? And sort of outline, if the person or if the people they are in contact with are at higher risk of getting seriously ill, then that might be a reason to go ahead and get it now. On the other hand, if they've recently recovered from Omicron, or that if they're thinking, if I get a booster now, I wouldn't want to get one again in the fall, then maybe it's better for them to wait. So that kind of information to help people, make that decision where we don't have a clear-cut should statement. I hope that helps.
It does, thank you. And I think rolling out that tool and just continued communication to help clear up that confusion will really help. At least in my anecdotal conversations, I think that's one of the reasons why we're not seeing more people get the first booster, is just a lot of confusion about, is that a may, is it a should, and how to make that decision.
Yes, thanks. We have about 4 more minutes of Barbara's time here and 3 questions. So maybe we can try to do them quickly. Monica, too.
Sure. Thank you so much for sharing those updates and the progress and the continuing priorities. This is sort of building upon what Julie was asking in terms of under 5. So I know that we've been hearing from a lot of our community-based organizations, partners, local health departments, that parents and families have been waiting so patiently. And now we're heading into end of school, especially for schools in the Southeast, and going into summer, and masks are off and people are traveling. And so I was wondering, I was reassured when you said that there's some collaboration with Dr. Levine at the secretariat level, but could you say a little bit more in terms of specific details that you might be able to offer in terms of the planning, collaboration, and the preparation that you're doing going into June and the summer, and maybe the tailored perhaps outreach that you might be doing in BIPOC communities and lower income communities? Because we know that while the numbers that you shared are really amazing in terms of numbers that have been vaccinated across the country, there's still persistent inequities that we're seeing in specific cities, regions of the country.
Yeah, so I think I can just sort of, in the interest of time, probably the best summary I could give you is that we are working with, we have a really pretty extensive network of partners, provider organizations, and community-based organizations that we've really been working with since the start of the vaccination campaign. We have very detailed operational planning to roll out the vaccines and to support their being available, and to support providers with information, to support community-based organizations with information for parents. Previously, it was just people who would get vaccinated, and we are our teams have been really thinking for a number of months and working quite intensively on preparing, sort of adjusting that for the under 5 scenario, where we expect vaccination in pharmacies will be less important. I'd be happy to tell you more, but I know we don't have very much time, so maybe I could follow up with you afterwards.
Thanks, Barbara. We do need to be respectful of your time. I think maybe only one more question from Octavio. Josh, I'm sorry.
Thank you, Barbara, for that great presentation. And maybe there won't even be enough time for this, but seeing that there's an inequity when it comes to the Hispanic Latinos and the vax rates you shared with us, is there a concerted effort? Because inequity, we know it's not about equality, but about where do the resources need to go when you see an inequity? Is there a strategic plan that you've identified to try to increase that vax rate?
Yeah, there's been quite a bit of work going on it, and I'm afraid I do have to jump to another call. I should, and I don't know if this is fair to John, but John is currently leading our response unit of the Chief Health Equity Officer, so he may be able to tell you more, but I can also share some information with him and with David to share with you. Thanks so much.
Appreciate it, Barbara.
Thanks so much,
All right.
Barbara. Thanks for your time. We know you need to scoot. We really appreciate
yeah,
that.
sorry.
No apologies necessary.
Okay, bye. Bye, everyone.
John, any follow-up on that one?
I think the best situation might be to get that package that information for Octavio and send it directly to you and share it with the other members as well. And I'll work with Barbara to do that.
Great,
thanks, John. I was just wondering about maybe what is the process for reaching out to trusted voices, the community engagement sort of procedures and skill sets, because I know how challenging it is. And the other one was how many of the materials and in what different languages are we using in the different modalities? So that would be really helpful. Thanks.
Thank you. We'll make sure to get you that information.
Thanks all. It's time to move on to our next topic. I was thinking that on NPR, when they move from one story to the next story, there's a little bit of a musical interlude to allow you to do a little bit of mind shift. So we don't have that. Maybe we can put that on the agenda for the next meeting, but imagine a short musical interlude now. And then it is time to talk now about the formation of our laboratory working group. And unlike the Data and Modernization Surveillance Working Group, this is our first presentation on this subject. And so we'll get to that in a minute, but I did want to let folks know, and we've told the ACD already, that good news for this committee as well. ACD members Jill Taylor and Josh Scharfstein have agreed to serve as co-chairs for this group. So thanks very much, you two. This is a huge task, and we really appreciate the commitment of your time and energy. And to lead off the discussion today, it's really my pleasure to introduce to the committee Jim Perkle, who I've known for a long time. He's currently the lead CDC official on lab science and safety. He's going to give us some background on this issue, and then with Jill and Josh will help lead us through a discussion of the draft terms of reference. Just want to make a quick note here. We can talk in more detail, but there's a slight speed bump in the clearance process of the terms of reference. So we can have a full discussion today, and you can express ideas, if any, for revision, but we will defer the vote on the terms of reference to our August meeting. That won't influence the formation or the work of the group, but it will result in a vote at our next meeting on the terms of reference. So having said that, Jim, over to you.
Okay, thank you very much. It's a pleasure to be here. If I could have the next slide, please. I'm going to organize my presentation today into several parts. First will be just a background a little bit on CDC laboratories and what goes on in CDC laboratories and I was asked to kind of provide, I hope you got the briefing materials in advance. We tried to send about 9 slides or so that would give some context on what CDC labs do. So I'm going to try to go through that actually rather quickly. And then I'm going to get to the laboratory quality plan. And then the third part will be the discussion of the terms of references. So in terms of CDC laboratories, this is your overall chart. If you know this chart, then you would be considered a CDC expert. And we have 6 CDC centers and NIOSH that have laboratories, and they are indicated here on the chart. And so it's spread all throughout CDC. There's some 2,500 laboratorians. There are over 200 different laboratories. So this is a major group of CDC, and I think you all are very familiar with laboratories in general. So I'm just pointing this out to show where this affects CDC and where these things are locations, where are the locations within our structure. Next slide. So overall, the public health role of CDC laboratories is to provide laboratory science that effectively supports the detection, diagnosis, treatment, and prevention of disease and harmful exposures in populations. And this is essentially to effectively support the mission of CDC. Next slide. And I have 2 slides here that go over, well, what are common laboratory activities? What are the things that laboratories are doing day to day? And so at CDC, a common and important thing that we do in the lab is that we analyze samples to find an unknown pathogen or a toxic agent in an outbreak. And those things I think you're familiar with. We work on developing better diagnostic methods for diseases and harmful exposures. We work to support the detection and diagnosis of infectious diseases, including extremely dangerous pathogens, those that require high containment laboratories. And so those are the CDC moonsuit pictures where you're seeing people handle things that are very, very dangerous. And of course, if any of you are ever interested, we could probably take you to see one of those laboratories if you haven't seen them before, and just to know the kind of work that goes on there. But high containment laboratories are a specialty at CDC. Some other labs have them for sure. But CDC, we work with some very dangerous things that require these BSL-3 and BSL-4 labs. We support surveillance of disease incidence and prevalence. A lot of these things depend on diagnosis from a laboratory and give us our incidence and prevalence information. The laboratory results identify vulnerable population groups that are at higher risk of disease or harmful exposures. And this is, of course, very important so that we can target preventive activities towards people at the highest risk. We also help to find risk factors that cause people to be at higher risk of disease or harmful exposures. Next slide. And we have really just 6 more things to say, but the first 3 on this slide really deal with the outward facing things that CDC does in collaboration with partners. We serve as a reference laboratory that provides quality testing to other labs. So there's some tests that are not really not available in many places. CDC has some tests that only CDC does. And we try to strive to be a reference quality laboratory so that we can provide quality testing to other labs who need a reference center to say, what should the result look like? If I compare my result to yours, I can be confident that the CDC labs did it right. I'm going to use that as the reference measurement. We conduct quality assurance programs to assist state, local, and other laboratories. And we have a lot of these that actually take things that we do at CDC, and we work with other labs to assure the quality of their analyses on these same tests. And this is many laboratories are involved. Certainly well over 3,000 laboratories are involved in this. We provide technical assistance on performance and interpretation of diagnostic tests. And then we help address some special problems like treatment challenges such as antibiotic resistance. A big effort is in supporting research studies to better understand disease pathogenesis, transmission, and virulence, resulting in better public health preventive actions. And we also work to help evaluate the effectiveness of treatments or preventive actions. So this is kind of the cast of things that are common in the CDC lab. So in the next slides, I'm just going to give you a light overview to say we have lots of infectious disease things, lots of chronic disease things, lots of environmental things that deal with many other non-infectious disease and NIOSH. We're going to go through some of these, but you've had these slides and you can look at these in more depth. But most of these labs are doing these common laboratory activities that I just mentioned. So I'm not going to go in a great deal of depth in these labs. This also will help you with CDC acronyms. If you can walk through this at the end and you know what NCEZID is and you know what NCHHSTP is, well, we give you 10 bonus points. And after a career, those bonus points add up. So these are, I think, important things to know in terms of the structure. So the National Center for Emerging and Zoonotic Infections is largely bacterial and viral pathogens. We have viral pathogens in several centers, but it is the largest center that we have that deals with bacterial and viral pathogens. And they also have a heavy emphasis in looking at identifying things that other laboratories cannot, and also look very heavily in antimicrobial resistance. Next slide. And then NCIRD is the Center for Immunization and Respiratory Diseases. And so they're the big place that flu works out. There would be the big place that we would deal with coronavirus. So the COVID outbreak had a major support here. They also deal with global polio eradication. Next slide. And so the National Center for HIV, Viral Hepatitis, STD, and TB Prevention, and this is a hard one, NCHHSTP. I don't think I know 5 leaders at CDC that can say that fast 3 times. So this is essentially AIDS, viral hepatitis, sexually transmitted diseases, and tuberculosis. They do exactly what you think they would do in that area. And we have a special national reference laboratory for viral hepatitis that's noteworthy. Next slide. The Center for Global Health has got a vision out for the world. They help more than 50 countries in outbreak response, building laboratory systems and pathogen discovery, big programs in parasitic diseases and malaria, and large laboratories in both of those areas. Next slide. And then we have a small laboratory in the National Center for Birth Defects and Developmental Disabilities that looks in persons with bleeding disorders and monitors for selected infectious agents and other abnormal factors. Next slide. And there's a large laboratory in the National Center for Environmental Health that looks at lots of things in the non-infectious disease area, monitoring people for exposure to environmental chemicals, assessing exposure to chemical threat agents, toxins, and radiologic threats, providing quality assurance, proficiency testing, and technical assistance for newborn screening in every state for the early detection of treatable diseases, assessing the nutritional status of the nation in cooperation with the NHANES, or National Health and Nutrition Examination Survey, working on addictive and toxic substances in tobacco products, including vaping products, and improving the quality of measurements in many state clinical and research partners' laboratories addressing chronic diseases, nutrition, and environmental exposures. Next slide. And then you come to NIOSH. NIOSH has its own set of laboratories, and they do things that are particularly interesting to me. I always like to hear about the NIOSH laboratories, but they're working to test and certify respirators and to make sure that protective equipment is working the way it should. They also develop methods for sampling and analyzing contaminants in air and in blood and in urine of persons exposed to hazards. And they do other interesting work in engineering controls as well. So a variety of stuff in NIOSH. Next slide. And so that finishes kind of just a brief overview of the kinds of things going on at CDC. And this presentation, though, is largely to focus on the CDC laboratory quality plan. Next slide. Now, Dr. Walensky asked me to take this position because we had some problems. You're very familiar with the problems that we had in February 2020 with our initial COVID test. And a review inside of CDC that came from that identified other problems that we really needed to address. And she asked me if I would come and work on this and to make sure that CDC labs operate at a gold standard quality level and that our labs are at the forefront of advances in laboratory science that benefit public health. So I came into this position about November 1st of last year with that goal. So that is our vision. And what we're presenting as a plan here is a strategic plan, and this is the vision for that plan. Next slide. So we have really 6 specific goals underneath that. And some of these are very large goals. So 3 of them are on this slide, 3 of them are on the next slide. And the things that we're talking about here do have a focus in the infectious disease laboratory area. Now, we are looking at other laboratories, but the thrust of what I'm going to present today is really working on assuring high quality in infectious disease laboratory. So the goals that we have are to make sure that we have excellent quality infectious disease lab methods with review that documents that excellent quality. The second one is to make sure that we have excellent quality infectious disease lab results that leave CDC that all pass appropriate quality control criteria. And thirdly, we want the infectious disease clinical labs to pass external reviews with only occasional minor deficiencies. Next slide. The fourth one is actually very important in pandemic response, and that is that we need to have a demonstrated effective capability to rapidly develop high quality diagnostic tests for new high-risk pathogens under emergency conditions in collaboration with private and public health partners. So that's pretty easy to read, but that is extremely difficult to do. So this says when we're under a very tight timeline of emergency conditions, we have to come out with a very high quality product. It's got to be able to diagnose a high-risk pathogen, and we have got to get it out in such a way that it can be applied quickly and do that in collaboration with private and public health partners. The fifth thing is that we want to have a single excellent quality manual for microbiological laboratories that covers all microbiological laboratories. And the sixth one is that we need scientists and sustained funding to be available so labs can ensure high quality and be at the forefront of advances of laboratory science that benefit public health. So these are the 6 goals that we've undertaken as a result of that review. Next slide. Now I've got a slide here on constraints. There are several things that make that task a bit difficult. The first one is that at CDC, we have clinical surveillance and research labs commonly together. And this is a very tough constraint. It is very common that somebody will work in a diagnostic laboratory in the morning that's a clinical lab. And in the afternoon, they'll spend 3 or 4 hours working in a research lab, working on, say, developing a new diagnostic assay. And it's the same individual. And so it's also possible that people could be working in a research lab, developing new things or doing studies. And then in that afternoon, they're running samples that are used for surveillance, that aren't used for strict clinical testing, but are samples that give us surveillance information that don't have patient information attached to them. And so it's very important for us that if we have a quality plan, that individual that's working in one lab in the morning and another lab in the afternoon is not schizophrenic about what they're responsible for, but we have an integrated quality system. So we have common quality standards that go across clinical surveillance and research labs. So this is a huge, huge challenge. And so this is something we had to spend a lot of time addressing. And the second I've already mentioned is that we've got to make sure that we have quality ensured for emergency rapid test development for tests that have high consequences for quality failure. And I'm sure you're all familiar with this. What I generally say is that there are 3 conditions that fight each other. They are quality, time, and resources. And if you've been in management, you've had to deal with this all the time, trying to figure out how you're going to balance those things. And of course, everybody that's above you in management wants everything at high quality in a very fast time and use very little resources, but those things fight each other. Well, at CDC, we're basically saying there isn't any kind of option available in terms of quality. We're locking quality at high. So there is no chance to say we had to develop it fast, so it doesn't have to be of high quality. That's not acceptable, so that is locked at high. And that means the only 2 things we really have to adjust are resources and time. An emergency locks time at fast, which means all we have to adjust is resources and make sure that the resources are trained ahead of time and the systems are in place and everything can work as smooth as possible. But this is a big issue, the very fast development work that has to be done, assure that it's of high quality and that we have adequate resources to make sure that happens. And then we have more than 1,700 people in infectious disease laboratories that are spread in 200 labs across multiple states and territories. So you can't just walk around the CDC campus and see all the labs. They're in Alaska, they're in Fort Collins, they're in Puerto Rico, they're all over the place. And the NIOSH labs are in multiple states as well. Next slide. So we came up with a laboratory quality plan, and it's really got these 5 elements, and the rest of my presentation is really going through these elements in a little more depth. So the first is an infectious disease test review board. The second is to have 3 separate quality management systems, one for infectious disease labs, one for non-infectious disease labs, and one for NIOSH labs. The third is to have a quality manual for microbiological labs, which microbiological laboratories, we call the QMML. The fourth is that we need flexible and user-friendly quality management software. And the last one is to have a biennial, that is once every 2 years, an external review of every laboratory, which would be clinical laboratories and surveillance laboratories and research laboratories. So I'm going to talk about these in turn. Next slide. So the Infectious Disease Test Review Board. Next slide. So the Infectious Disease Test Review Board is a board that we have already pulled together, and its function is to review test methods developed at CDC before they are shared with external laboratories. And in that review, to ensure the quality of the test and the transferability of the test is suitable for intended use. So the concept here is that a person who develops the test then has to put it up for review by this board before it can be shared from CDC. So who performs the review? Well, we have a panel of at least 3 scientists who have expertise in the method science. So if it's RT-PCR, we have people who are experts in RT-PCR. If it's an enzyme immunoassay, people who are very familiar with an enzyme immunoassay. But they cannot be involved in the test development, and they must recommend approval of the method to the test review board, who then votes and provides final approval. Next slide. So when they review it, when these 3 people review it, what are they looking at? Well, for those of you that are kind of familiar with lab, this is what we would classically call a method validation review, where we look at the test performance specifications and performance of the method and see if it's suitable for the intended use. For those of you who are more kind of epidemiologically bent, you definitely will recognize the value of diagnostic sensitivity and diagnostic specificity. We also do a careful review of limit of detection, sample collection and stability, quality control criteria. Do the quality control criteria evaluate all the parameters that influence the quality of the measurement? And then can we have successful transfer of the test to another laboratory to show that it all really works, not only on paper, but it actually works in reality as it's transferred to another lab. Next slide. Now, we talk about diagnostic sensitivity and specificity. This is a 2x2 concordance table. I think most of you have seen this at some point, and it's not really the diagnostic sensitivity and the diagnostic specificity that is our ultimate goal, but our ultimate goal is the predictive value of the test. So this is that same 2x2 concordance table showing how sensitivity or the true positive rate is calculated, how specificity or the true negative rate is calculated. And of course, both of these are much better if you have low false positive and false negative rates. I generally like to talk about these things by talking about low false positive and low false negative rates, because from a communication point of view, people clearly understand that. Some people have a difficulty just grasping that sensitivity is a true positive rate or specificity is a true negative rate. And if you don't deal with it often, sometimes it just slips through your mind. But we really want to find the test's positive predictive value and negative predictive value. And those are shown in the formulas here. And of course, we have better positive predictive value and better negative predictive value when we have these low false positives and low false negative rates. So kind of the short summary here is it always benefits you to get your false positive rate and your false negative rates as low as possible. It helps highly in predictive value. Of course, we've got to take into consideration that predictive value is a function of prevalence of disease. So it does have to do with the population that you're sampling. Next slide. So this infectious disease test review board then is actually one of the very big things that we wanted to put in place. Had we had this board in place in February of 2020, then that test would not have been shared and the problems with the test would have been identified. And so any test now that goes outside of CDC has got to go in front of this board. And the board began meeting in early March of 2022. And so anything from here on that CDC puts out has got to go through the approval of this board. So this is actually a very major check, a quality check at the end to make sure in all the processes that went on is the product that we're going to send out an excellent quality product suitable for the intended purpose. And this board is what verifies that. Next slide. 3 separate quality management systems. Okay, so let's go to the next slide. So one of the early things that I had to address was there, of course, have been many quality meetings at CDC over the years, and there are a lot of quality systems running around CDC. There have been systems, concerted efforts to try to bring things together, but one of the difficulties had been that CDC has got such a diverse set of laboratories that if you talk about a quality management system that fits everybody, it really can't get down to the detail that it needs to get to. So one of the first things that we did is to say, we're going to have 3 separate quality management systems. We're going to have one that deals with infectious disease labs, one that deals with non-infectious disease labs, and one that deals with NIOSH labs. And again, this allows us to get down to the depth, to ask really specific questions. And this is kind of analogous if you're familiar with hospital laboratory setups. There's a microbiology laboratory in one place, and there's a clinical chemistry laboratory in another place. And the quality control systems and the quality management systems that those 2 laboratories use are distinctly different. And we're in one way doing that at CDC, saying we're going to focus heavily on microbiology laboratories with one quality management system for them. And we're going to go deep so we specify quality standards that really make a difference in quality output, and do the same thing for clinical chemistry labs, and do the same thing for NIOSH. And NIOSH has to have more custom related things because of the specialty of their labs. NIOSH actually has a lab that is literally an underground mine. It is literally a mine underground. So it's got to have a specialized quality management system. None of these others would really fit. So this is actually a big step because it allows us, again, to get to the depth of looking at quality standards that are most relevant to quality output from these different labs. Next slide. And now I'm going to talk now on the quality manual for microbiological labs, again, the QMML. And I'm going to have about 5 slides on this because this is a huge anchor of all the effort that we're doing. The next slide. So the concept for this manual is that it'll be a one-stop resource for excellent microbiology laboratory quality practices. Now, for those of you that have been in the lab, you may be familiar with the biosafety and microbiological and biomedical laboratories, which we commonly call the BMBL. And you can just walk out of this meeting and you're not a lab person and walk up to a lab person and say, oh yeah, we heard about the BMBL. Well, you'll gain bonus points from them because they'll think you're very knowledgeable. But this is the go-to safety thing in the laboratory. You want to know how you're going to deal with a very virulent pathogen. The BMBL will tell you how to do it. So we want to have, just like that's the go-to manual for safety, we want to have a go-to manual for quality. So the mantra at CDC would be safety first and quality second. And we want to make sure that we set those standards and that they're high standards for CDC. Now, the standards set in the quality manual will exceed the standards that are required by CLIA for clinical laboratories, and will also exceed the standards that are required by FDA when they review methods or have to approve methods for use. And we'll have in this quality manual separate sections that handle clinical laboratories, another section that handles surveillance labs, and another section that handles research labs. So that's a little bit about what its purpose is and what's inside of it. Next slide. Now I'm going to spend a minute or two on this. You don't have to read everything that's inside the bars. It is important that with your eyes, you can tell the teal from the salmon orange from the purple blue. And so you got to tell the bottom from the top here. So this is what we eventually did to address this problem that we mentioned under the constraints, that we had people working in different kinds of laboratories, and we needed to make sure that our quality requirements for those different kinds of labs were integrated and made sense. So if you kind of look at the field, the clinical laboratories have a regulation that CMS oversees called CLIA, and they come and have requirements that every clinical lab has got to meet. So if you go to a hospital, you get a test, those laboratories have got to be certified by CLIA, that they are passing all the quality standards that they should. And that's what we would call a clinical or a CLIA lab. If you went to a research lab and said, well, what quality system is there? There is no quality system that's set up in the US that says this is what research labs should do. There are a few attempts that have been made in the literature, and none of them have generally been successful. So what we're trying to do at CDC is to say that there's some components in a research lab and a surveillance lab and a CLIA lab that are common. And when we have these common elements in laboratories, we want to make sure that they have the same quality standards for common elements. So if you look out under that research lab out on the far right, a research lab should make sure it's got good test documentation, including method validation, like we just talked about, sensitivity, specificity, limit of detection. It needs to have quality control sample rejection criteria. It's got to have proper calibration. It's got to have the right kind of quality control criteria, all for a test. If you're a research laboratory and you're using a test, you need all those things. It needs to have the ability to address non-conforming events, NCEs, and to come up with corrective and preventive actions, sometimes called CAPAs. So if an instrument is not working right and the O-ring is leaking and it's not performing it the way it should, you've got to say that's a non-conforming event. We've got to go figure out the root cause for that. Then we have to implement a corrective action and a preventive action if necessary, and all that's got to be documented. So the next researcher that comes along will know that, and we won't have that problem again. And so a research laboratory has got to do that. A surveillance lab has got to do that. A CLIA lab has got to do that. For personnel, you have got to document duties, training, competencies, qualifications of your people to make sure that they're adequately trained to perform the tests that they're doing. You have to do that in a research lab, in a surveillance lab, also in a CLIA lab. You've got to do equipment maintenance and function checks. So the things in teal are common elements that we find in research labs, surveillance labs, and CLIA labs. So we're setting up in this quality manual to say they're going to be standards for research labs, and for the common elements that where research labs overlap surveillance labs and overlap CLIA labs, it's going to be about 95 to 100% the same quality standards. There's a little wiggle in there, but almost all of them will have the same quality standards. So the person that walks out of a CLIA lab in the morning, having worked in the lab in the morning, would walk into the same quality standards in the afternoon when they're working in the research lab. Now, moving from a research lab to a surveillance lab, what do you add? Well, now you're getting specimens in from the field that are surveillance specimens. So you have got to deal with issues like sample collections and shipping and storage and handling and stability studies. And so we've got some of those things listed in that kind of orange tan section there, I guess a salmon color. And those are also things, though, you have to deal with in a CLIA lab. So our quality standards for things that are in surveillance labs and in CLIA labs are shown in the salmon, and we want those quality standards to be the same. Now, when you move to a CLIA lab, you have new things because now you have samples coming in that relates to specific people, and results are going to be sent back that get to someone who's managing patient care. So you have to have other things, test requisition, test records, test reports. You have to have a complaint system. You have to have special security of personal data. You've got to have a system to handle sample referrals. So it isn't meant that every box here is exhaustive, but this concept of stair-stepping up, starting with research and going to surveillance and going to CLIA, and common elements having common quality standards is the novel thing that we're doing. Next slide, please. Now, A second thing that's really big in the quality manual is that we are convening method expert groups. And by that, I mean 3 CDC lab scientists per group. And each of those groups develop an excellent test method quality standards for each method type. Now, a method type, you'll be familiar with this from COVID because a lot of laboratory stuff has come out with COVID. So a PCR test or an RT-PCR test is a method type. An antigen-based test, like you get the very rapid test for COVID, well, that's a method type. Enzyme immunoassays is a method type. Serology is a method type. So each one of these has got an expert group that comes together and sets up what is an excellent set of quality standards for that method type. And then every CDC method that is in that method type must meet those standards. So right now we have an RT-PCR group that's working. That's our first group that we're trying this out on. And they're coming up with excellent standards for RT-PCR. When we finish that, then every RT-PCR assay at CDC will have to meet those quality standards. And if they're missing some data, they're going to have to generate data. And they will, excuse me, they will be written up according to really some excellent test documentation standards as well. And so they will be of such a quality that somebody on the outside could pick it up and would really know all the things they need to know about executing that test and would be able to see all the method validation and would be able to see all the work that shows it's high quality and suitable for intended use. So these method expert groups are another brand new thing so that we can set what is the excellent quality standard and then make sure that everybody that CDC that's working in that method meets that quality standard. And we'll do that for each method type. Next slide. I'm not going to go through these, but the kind of things they deal with, the quality standards are shown here. It's a long list of things, and these are very important things in method validation. I do want to mention at the bottom that there will be a transparent listing of all the data that's used to validate the method. So if somebody comes in and says, you know, you were developing something for Zika, did you happen to test all the other flaviviruses to make sure it didn't cross-react with your assay? You can say, yes, we did check all the flaviviruses, and here is the results for everything that we tested to validate our method. And you can see everything about it. And if somebody else says, well, did you have any outliers? You say, well, here's the raw data. You can look and see if there are any outliers. No, we didn't have them, but we are publishing the raw data, not just the calculated values. So everything that goes into calculating diagnostic sensitivity and specificity, every piece of raw data that goes into that calculation will also be shared in a raw data form. So the process is completely transparent. Next slide. And I just want to mention when they work up the test documentation for these methods, we're having 2 special sections put into these methods. Every single method at CDC will have a first section that is safety pointers. And this will be about 5 to 10 pointers to pay a special attention to when you're running this assay in the laboratory. And the first 2 comments that are always going to be on every assay are shown here. If you're not certain about the safety of every step in this procedure, then stop and consult your supervisor. And the second is, do not hurry, work at a steady, controlled pace. The reason we're putting these in is these are things that cause problems with safety. People don't want to share because they're afraid that people will think they're really not competent enough or know enough. So they don't ask questions when they're new. And we need people to know it's very important to ask questions on safety anytime you have a safety question. And also don't hurry. Problems are so often related to people that are in a hurry. Now they can justify why they're in a hurry, but they're in a hurry and that causes safety problems. And then list other things that may be specific to this method, like all steps require double gloving. That's not true in every assay, but it's true in this assay. So this lets us get the safety things out in the front where people can see them right at the beginning of the method and say, these are the special safety things for these method. Again, up to around 10. Next slide. Now that safety pointers is followed by quality pointers, and we have the same thing. If you are not certain you can perform every step in this procedure at the quality level needed, then stop and consult your supervisor. The same principle as with safety. And then this is common in the laboratory, they'll say something like heat something in a water bath for 30 minutes and at 56 degrees. Well, we've got to write things down like heating time must be 30 plus or minus 1 minute, and temperature must be 56 plus or minus 1 degree centigrade. So people don't heat it for 45 minutes saying, well, I surely heated it for 30. That's disastrous in the lab. And some of this might seem kind of simple to you, but this is really based on what is it that traditionally has caused problems, and we want to make sure in advance we keep those problems from happening. So this would be about 5 or 10 quality pointers that are specific for this assay, things you want to make sure you attend to, that if you don't tend to, will come back and bite you. I know it seems very common sense, but this is not done, but we will be having this for every CDC method. Okay, next slide. So that's the quality manual. That was a lot on the quality manual, but the quality manual is gigantically important. And of course, the quality manual, when it's done, will be freely shared, be available to states, available internationally. It'll be sitting on our website where anybody can use it. We would encourage them to use it. The next one, we're almost done here, is the use of flexible and user-friendly quality management software. So in a laboratory, next slide, in a laboratory, you'll hear people talk about quality management systems, or you'll hear them talk about a LIMS. And I just want to be clear on this. A LIMS is a laboratory information management system that tracks the sample from cradle to grave, from the time it was first collected till the final report is sent out. That's the LIMS. It keeps track of it all the way, make sure that it was sent and analyzed correctly, the report was generated correctly. Very, very valuable. But totally independent of a laboratory information management system is another kind of software, which is a quality management system software. We call it an EQMS. And these things go in and handle things like document management. Try to get the documents, make sure that you've got test methods and SOPs and everything else done in a, in a manner that you're looking at the latest version and all the important things are being done with it, that you track non-conforming events, CAPAs, training records, competency testing. It's largely administrative, but really helps manage all the documents and all the things that go into quality laboratory operation. So we're trying to get a very good package that is user-friendly as much. We're trying to make it like an Apple app, as user-friendly as possible, so people can really benefit from it. And we can make sure these things are up and operational uniformly in our labs. The other advantage is if we have it in all our labs, then at higher levels, we can find people, we can look across the CDC labs and make sure that they're taking care of all these things, like their non-conforming events and what their corrective actions look like. So this is something that we're pushing very hard. And I know I'm short on time, so I'm going to go to the next slide. And that is that all the laboratories have got to have a review every 2 years. And so for CLIA labs, the next slide. So the next slide is for CLIA labs, this has got to be done. This every other year review has got to be done by CMS or by a couple of surrogates for CMS, the American Association for Laboratory Accreditation or the College of American Pathology. They both can perform CLIA reviews. And we have worked out special arrangements with the American Association of Laboratory Accreditation so that we will have special reviews for our surveillance and research laboratories. And they are very interested in making sure that this research thing can get off the ground, because general quality management systems for research labs aren't available. And if our thing works out well, then A2LA is very interested in promulgating it out to the larger research community, both in the federal government and state governments and also in the private sector. So I think, help me with this, David, am I going to stop and not say the terms of reference now, or do you want me to run through the terms of reference real quick? I can't remember what we agreed.
Thanks, Jim. I think what we agreed was, given the amount of material here, we would let the committee come up for air a little bit.
Okay.
The purpose of this background was to, number one, as you've done so well, outline the scope and scale of laboratory operations at CDC. And then second, we wanted the committee to know about the huge amount of work that you've already done and CDC has already done in approaching this issue of laboratory quality at CDC. We will go to the terms of reference, which is what you're specifically asking of the committee. but did want to give folks an opportunity at this point, if they had any questions about scope and scale or about the work that you've already done, to be able to ask. And to you, Josh.
Thank you so much. And thanks for such a great presentation. I think it would be helpful. Everybody has read about the COVID test problems in early 2020, but there are obviously some other things on your mind that you're trying to accomplish with this laboratory plan. What are those things? And either by way of reference, and I don't mean just generally to have excellent, labs. I mean, you don't want employees exposed. Has that been a problem? What are the challenges that CDC labs have had that you're really hoping to resolve beyond just the challenges with the one test that happened?
Yeah, right. So they're largely reflected in the goals. So kind of every goal is really just addressing a problem that we've had. So when we say we don't want a test result shared that isn't of the quality standard that we want, that's what happened in COVID. That was shared before. So that was a problem. We have had some problems with some test results not going through as thorough a quality review as they need before they're shared outside of CDC. That's why that's one of the other goals. We've had some difficulties that when we've had an external review, they found deficiencies in some laboratories that weren't just a few casual deficiencies, but they were things that we felt were more than just a few casual deficiencies. So we didn't want to have that. Another big thing was there wasn't an overall set of quality standards that was uniformly accepted. We had lots of pockets of people who had worked on quality and had their own idea, but this set of quality standards was different than this. And if you said, what was the CDC standard? This person would say something different than that. And we really needed to get those people together and agree, what is the excellent standard that we're going to adhere to? We can't have all these different things across different centers. And so those were the big things. And we also have to give the director the assurance that when something comes out of CDC, she can stand on it and it's going to be absolutely right, because she has got to make decisions that have got a lot of implications, and you can't be second guessing, wondering, well, I wonder if the lab really got that exactly right. She's got to be highly confident the lab got that exactly right. She can stand on it.
Thanks, Jim. Really helpful. Jill.
Hi, Jim. Thank you for all the work you've done so far. It's just really great and reassuring. Can you talk a little bit about the partnerships with especially public health partners in relation to the development of a test for a high-risk pathogen? Lab failures can happen in any lab for all sorts of reasons, not just a quality issue. And so we have to build redundancy into the system. So can you talk about that?
Yeah, that's a very excellent point. So that is something that we're moving. So the plan right now is that if we end up in a situation where we have a rapid test that needs to be developed and there's significant consequences for failure, then at CDC, we do not want to be the only lab that's working on it. We're going to give it our best shot, pull the best people together to do it. But we want to have at least 2 other laboratories that are working independently and parallel on the same task. And we want to fund them in advance so that we're giving them some funding to help them out to be prepared so they can work rapidly on that. And so my preference is that be towards state laboratories. And I think that there are definitely there are a bunch of excellent state laboratories. If we work together with them, then if we have something really difficult and risky on our plate, we have 3 independent shots. And if the state laboratory comes out with the best method, we'll go with that. We'll go with whatever the best method is. But you're exactly right. We're trying to say in the future that redundancy is a requirement, not an option.
So I totally support that. I am nervous that this happens sooner rather than later. We don't know when the next pathogen and it's not just pathogenic tests, pathogen tests, it could be, chemical tests, whatever, but we don't know when the next event will hit us. And I just urge CDC. I know you've got a heck of a lot on your plate, but I urge CDC to keep that one high on the list, please.
Thank you. Yes.
Yeah, thanks, Jill. Just want to let members know that we actually have a fair amount of Slack later on in the agenda this afternoon. So let's go ahead and get these 3 questions. Josh.
Thank you. So quality being just such a critical goal and the focus of so much effort, a good quality plan is one component of quality, but it's obviously not all of quality. You know, among other things is performance management, for example. Is the plan being followed at different levels? How much thought have you given to that? Is that something that would be useful for the work group to be assisting on? Like, you have the quality plan, but how, you know, what's the right level of transparency? What's the right level of oversight? How do you manage to a quality plan? How do you think about that?
Right. So I didn't go, that's exactly right. And I didn't go into detail on that because of time. But what we have done is, in the past, there has been a program called the CLIA compliance program in DDI, in the infectious disease centers. And what we have done is we have changed that, made it much bigger, and put it up towards the office of the director, of the deputy director for infectious disease. And it is a laboratory quality office, and they are assigned for the infectious disease labs for that very purpose. Their job is to have oversight to make sure that when people are engaging in these things, that all of this is checked and it gets done. Now, there are a couple of checks that happen. We have a review at least once a year that's an internal review. And then every 2 years, according to the plan, we have an external review. So we have a review literally every year that are looking to monitor to see how well these performance requirements are being met. And then if people don't meet the performance requirements, there's a pretty straightforward path of citing a deficiency. They have to come through with a plan that fixes the deficiency, and then you check in certain periods of time to make sure that that fix has been sustained. So we have a lot of effort going into that. In addition to that, the Office of Laboratory Science and Safety, which I head, is another layer above that takes a look and says, we want to make sure that review being done by that body in DDID is done well and is up to snuff and doing all the things that they do. So we actually have a couple of layers on that, an external review, formal internal reviews, which literally are coming into the laboratory and doing an in-depth review. And so we feel pretty good that we're going to be able to track where there are problems, and people will be held to make sure that they come through and make these quality changes.
Just a super quick update. Is there any layer of tracking that's not like on an annual basis? Are you trying to, basically,
Sure. Yeah.
Set up a system that would give you an early warning of a problem?
Yeah, and more than that. Well, yeah, I may have to have kind of an offline conversation with you so we don't go too far, but there's lots of things. But one big thing that we're talking about in this quality management software is that if we get this into every laboratory, then a center director could sit in their office and take a look at all the non-conforming events in the laboratory in the last year without talking to anybody, not doing a data call or anything, just a direct query. So we'll have the ability to report on quality metrics. And then when people are failing quality control criteria, that enters the system as a non-conforming event. So we have a lot of indicators that are very heavily related to overall laboratory quality that we'll have direct access to and are reviewed on a regular basis. But in addition to that, we have things that cascade down in the structure where people are going and visiting labs and documenting what's going on. So we're actually pretty thorough on that in terms of what the plan would have. But I can give you more information if we talk offline. It's a little more detailed.
So we can do Octavio, then Julie, and then we'll go to the discussion of the terms of reference. Octavio.
Yeah, Jim, great presentation. Really learned a lot. I really like the major quality check of the ID test review board model and concept. Now, if you said this and I missed it, I apologize. But are you also sharing and exporting that concept to other labs, not only other labs nationally, but even internationally? Because I think it's a really important quality check that you guys have identified and have created.
Yes. So the simple answer is yes. So when this quality manual that we're talking about describing, it will be in the quality manual. So it says, this is how this works. And so it may not be that everybody has got the same structure that we have at CDC, but the concept of having a test review board independent of the people who develop the test will be well written up in that. And again, I've made this presentation several times, and I've got people asking me, when you finish one chapter of the quality manual, can you send it? We just want the first chapter because everybody wants the piece of this. We're not handing it out chapter by chapter, but this is something that when we do finish will be a living document. We'll keep improving it, but it will be available to lots of labs, and it'll have the thing in it that you're suggesting.
Thanks, Julie.
Thanks, Jim. Great presentation. It's this quality. It seems like the focus of this working group is really on the quality work that you all are doing, which is so important. So I think my question might be a little bit tangential, but I hope you'll address it. I think when I think back about the pandemic and early on, when maybe mid-pandemic, there was a lot of concern about the US's ability to detect variants, COVID variants. And so I was wondering if the genomic surveillance initiative that Barbara mentioned earlier, if that's really looking at helping to build the capacity, whereas your focus is really primarily on the quality. I just would love to hear a little bit more about that, because there was so much concern expressed about our ability to detect the variants, and wondering what CDC is actually doing to address that issue.
Right. So yes, my focus really is on the quality. I just happen to know the answer to that question, so that I can tell you that there's a huge emphasis at CDC to make sure that we have capacity to be able to do a reasonable sampling to spot variants when they're coming along. No, we were not set up for that at the beginning. So many things have changed in the last 2.5 years at CDC. I mean, Dan's talk this morning, lots of things have changed in surveillance, just night and day. And some of them are great because we're into some authorities we've never had and have wanted. But this is one of those that's a big change. So genetic sequencing keeps getting faster, but you're still going to need to have 10 or more labs out there that CDC is working with that are processing through this data. No way we can handle that at CDC. We have some things like that set up now in the response. So we have things coming through. The question is, what's it going to look like after the response when we don't have an emergency going on, when funding streams are different? Then how is that going to be? But at a minimum, we're going to have the capability and have relationships built up with a number of labs that if something else happens, we can rapidly build up this stream of genetic sequencing and get it to a fast pace. Now, where are we going to go in the interim? How low is the valley going to go on number of tests? I can't answer that, but we're for sure going to have the relationships built up. So if something like this happens again, we can engage at this high level very fast.
Great, thanks, great question. And so Jim, let's move on to the presentation about the terms of reference for the working group.
Okay, so I'll try to do this fast. If I can have the next slide. And the next slide after this. And so the next slide after this, there we go. So the primary charge, of course, is to provide work products to assist the ACD in developing recommendations on the scope and implementation of improvements to strengthen the quality of work within CDC labs. And we've mentioned these things already. This is the gold standard quality in maintaining the forefront status in laboratory science that benefits public health, the ability to do rapid, high-quality diagnostic tests for new high-risk pathogens, and recruiting and retaining high-qualified scientists. These are big areas for us. Next slide. But the specific charge that we want to deal with is that we have a question that sometimes comes into CDC. CDC is sometimes the laboratory of last resort. So we get test specimens that can be less than acceptable or even unusual specimen types. Now, there are regulatory requirements that say in advance, you have got to test for stability of your analytes and specimens. And if something's been sitting out for 3 days on the counter and you only let it sit out for 1 day on the counter, well, you can't make a measurement on that. But CDC often, as the laboratory of the last resort, will get specimens that are less than acceptable. We would like to do whatever analysis that we could do, but it flies in the face of what we have to say in our regulatory requirements, which is if it does not meet our criteria, we have to reject the sample. So we're in a conundrum with this. And we would like to get some advice on how we can report results with appropriate limitations to the interpretation. So for instance, the top might say, not a CLIA test result, must be interpreted only within the context of the description given here, or something like this. But it's valuable because it's very difficult to come up, say, with a false positive for an infectious disease. And if we get a positive in a kind of a questionable sample, it could really influence us to think that that person did have the disease. But if we get a negative, there are lots of ways that that could come from not handling a specimen right or from sample degradation. So it would be hard to interpret a negative result, but we would have pretty good confidence in a positive result. So we've got to navigate this so we can still run these specimens we would like to, and we would like some advice on how to do that. The second one is that the QMML is going to be a primary resource for quality standards for ID laboratory operation, and we would value the review of this laboratory working group for that manual to provide us comments and edits that they recommend. We think that that would improve the quality of the manual. Again, that will be coming out somewhat in pieces. It could be done, but it'll take a little while for all of that to get out. Next slide. And then the third one is the same thing that Dan brought up, that excellent laboratory scientists are certainly essential for high quality advanced laboratory testing. And how can we better recruit and retain outstanding lab scientists to ensure this high quality advanced laboratory testing at CDC? It's extremely common at CDC for people to come in, get 3 years of training, really understand some advanced techniques, and then go to the private sector and make 50% more money. And there's very little we can do about that. We have got to come up with something that allows us to recruit and retain outstanding laboratory people, because we are not competing with the private sector. And this is crucial for public health, just absolutely crucial. I don't know how to put more emphasis on that. And finally, the thing that David Fleming mentioned, that in the federal budget agreement, they asked that there be an external review to take a look at the shortcomings of the COVID-19 tests, as well as policies, practices, and systems to mitigate future issues. This laboratory quality plan that we have developed and we are implementing right now, we believe addresses that, but we would like an external review on that to have a group look and say, does the quality plan address the previous deficiencies and mitigate future challenges in diagnostic test development for public health outbreaks? So instead, I don't know how many Dan had. It seemed like to me Dan had 6 or 7 really, really tough ones. We limited it to 4, but they are tough things to do. So those are the places that we're specifically asking for input, but we would always take input from the group if they felt that they had something that would be beneficial to CDC, but these would be our focal points. And that's it.
Thanks, Jim. So we'll open up for a comment here, just to reinforce the speed bump. The last item there is in the current draft terms of reference that was sent out to you. My understanding is that CDC is still waiting for essentially official word from HHS that the working group construct is appropriate to address this issue that was raised as part of the budget document. And so we will wait until we hear definitively from HHS on whether or not they want and would agree that that should be part of the charge of the working group to take an actual vote on the terms of reference. So we'll defer the vote until our August meeting, but would especially welcome comments on the content of the terms of reference, because we do have now a little bit of leeway in being able to redraft it if there are significant issues that committee members would like to raise about the existing terms of reference. So opening it up for that discussion now, and Nirav.
Jim, thank you for this presentation. Seems like there is a lot going on, as you said earlier, in terms of quality, and kind of building off of Josh's question, I wonder, there's a lot of text around the QMMI, and I wonder if focusing on the manual is not going to give enough space to all the other things that you want to do. Maybe it doesn't belong in the tour, maybe it does, but how do we improve? How do we put the systems in place? What are the I think Josh mentioned performance management opportunities there. There's things like inspection of labs. We did that in New York State, but we knew we didn't necessarily need to inspect every lab every year. There were labs we wanted to inspect much more, and others that we could probably get by every 3-4 years. So starting to think beyond and outside in terms of quality with the big Q. Obviously, what you've described is foundational. You without the standards, you're not going to get anywhere.
Yeah,
but I feel like we need more in this tour to really get to the full scope of quality. And I don't know how you're thinking about that, whether it needs to be here or not.
So, yeah, I mean, I understand what you're saying. I think that the probably part of it I may not have explained as well. The quality manual certainly includes the standards, but you would read the manual as a laboratory operations manual. It includes all the quality standards, but it includes all the things that you're mentioning right there. And I mean, we are going to do a review of every lab every year. That is going to happen. That's in the quality manual. That will happen. There are things in the quality manual that talk about, I mean, performance management, you would have to say that we're an overkill on that. We have got so many checks and people going in and doing it, and they will be required trainings when people come in. So if somebody comes into CDC, they have to take certain safety trainings to make sure they don't hurt themselves in the lab. They're going to have to take certain quality trainings to make sure they understand quality, how CDC does quality, and how they do quality in the laboratory. So that all of these things are in that quality manual. It's probably better to think of it way beyond just having the standards, but it's the operation of how laboratories work and how all these things are checked. So I believe all that stuff is not going to be just sitting on paper in a quality manual, but the big difference is these will not be guidelines. These will not be recommendations. These will be requirements. So you can consider them as CDC policy, not we recommend you do this, but you must do this. And that's a very big change. There hasn't really been something like that coming out of CDC in this arena of laboratory operations, in all the years that I've been here. And so, and which is 40 years. So that's a long time. And so there's really a tremendous amount here that it deals exactly with what you're saying. It's just hard to put one word on it, and we're calling it the quality manual. It could have been called the Quality and Laboratory Operations Manual, but then that's too long. So we called it the quality manual. But I think once you see it, those things you're talking about will be mainstream in it.
Thanks, Jim. We'll go ahead and give Josh and Jill the last word on this. Just before you two speak, though, I did want to make the committee aware that, as with the Data and Surveillance Working Group, we are moving ahead to fill out the membership of this working group with outside members beyond the ACD. And that includes the same Federal Register notice that will go out on the 4th with a 10-day turnaround time. So be thinking, if you know of folks that might be good for this working group, please encourage them to apply. And I would ask Josh and Jill in their final comments to also, like we did with data and surveillance, talk a little bit about the nature of the expertise in your discussions with CDC that you're seeing would be important for this group. So first, Josh.
I'm actually going to defer to Jill. Is that okay? And then I'll go next.
So first of all, the expertise of the work group. We're looking at people with clinical experience, public health experience, regulatory experience, state health officers with oversight of labs, so multiple levels there. And if you've got any suggestions of names, if you would let Josh and I know, that would be great. But going back to the terms of reference, I don't see anything particularly wrong with the terms of reference in any way. My gut feeling, though, is that they should be broader. I'm focusing on something that Jim said about how labs have changed since the pandemic. And that's not just CDC, that's every lab in the country. Just look at the impact of genomic sequencing that was brought up. There's just change in every area. And I think that, changes in the lab that I used to run in New York. I think that given that we've got time for a vote before the August meeting, if it's appropriate for us to have a little more discussion with Jim and John and David about how we may define a somewhat broader scope in the terms of reference to address other things that in no way are critical of CDC, but that are affecting diagnostic labs generally across the country. Just a thought that I think would be helpful.
Thanks, Jill. Jim?
Yeah, I mean, Jill, I'm always open to your ideas. I value your assessment and your expertise. You know, when we were trying to do the terms of reference, we were actually trying to prioritize some things so that we didn't give the work group too much and too wide. But it is a balance, and there can be some more things that we put on the list. So for instance, we could talk about, you know, the difficulty of developing something in very short order, and could we have some more input on how we could do that better? That's something that we're certainly working on. We think we've got good ideas on that. So we kind of put ourselves together and said, where are places where we really need some good ideas on some things that are difficult, that we're having very hard time moving forward on? And where are some things that we say that outside review of what we have done would be highly beneficial? Now, the things that we're doing in terms of the quality manual is a complete culture change here. And people looking at things that we have in there is very, very important. And we will have lots of discussion on this as we air it out with CDC, as we air it out with APHL. We're also sharing the quality manual with FDA, and FDA has agreed to review it. So we're going to have lots of back and forth on this, but this is going to be really a gigantic thing. And if I just gave you one term of reference and said, we'd like you to review the quality manual, that could take you a year. You know, just that would take you a year because there are lots of issues. I don't want to go over it in this group, but just dealing with what are the quality parameters that say that your genetic sequencing has given you the right result. Genetic sequencing is a whole different kind of testing. You don't have something present or absent, you're looking for a sequence. And so what quality parameters do you use to assure you have adequately looked for and not missed anything, and you're not saying something's there that's not? Well, this is a new area and nobody has really sorted this out in the literature. Well, that's something that we're sorting out as we're trying to write the manual. We're having to deal with all those issues. Now, that's something that we could forward to you guys and say, okay, here's a whole new way of doing something. It's very specific, it's very important, but we're trying to cover that in CDC first to see what problems we have and then send it to you kind of as part of the quality manual for your comments. But I'm very open to going wider. I just don't want to overload you guys. And I understand that in the future, we can have opening to add more things. We're very willing to do that. I consider the 4 things we put down here to be a lot of work. So I'm a little sensitive not to overload you and you just say, we can't do any more for you. But the answer to your question strictly is I'd love to have the conversation. If there's something specific to add that you think would be a good idea, I'm very open to it.
I think that, thank you, Jim. I think that this is an opportunity in time that if we let it go, we'll lose it. And
okay,
that's what's pushing me.
Fine.
Thanks, Jill. Josh.
Thank you. And I was just going to suggest maybe for that future conversation, a very, very small change that would be about the quality manual and its implementation. I'm concerned, and you know, you mentioned you're going to send it to FDA. I would be willing to bet that when FDA looks at this, they'll see a written document as just one piece of the quality puzzle, hard to interpret outside the context of its implementation. And so, you know, understanding your focus on the quality manual, it can be hard to say how, you know, useful it is entirely without understanding how it will be put into practice, what the oversight will be, those sorts of things. So there may be a way to limit some of the scope while keeping it focused on the quality manual, but not have it just sort of a textual analysis. So anyway,
yeah,
that's kind of my thought for further discussion.
Josh, we may. I'm a little concerned that the name has thrown things too far. In the first chapter of the quality manual, it lays out the responsibility of the CDC director, the deputy director for infectious disease, each CIO director, and all of their responsibilities on implementing what's written in the manual. So it is very much an operational instruction rather than just setting up some quality standards. So if you read through it, It tells you how laboratories operate and what are the checks and balances to make sure they're operating correctly, in addition to saying when they operate, they should meet these certain standards. It really does have both those things in there. I'm feeling after this discussion, I should rename it the Quality Management and Laboratory Operations Manual just to make sure everybody gets it. But I think if you read the first chapter where we talk about personnel responsibilities and who's responsible for what, it becomes clear that this is not a document on the shelf, but this is an operating thing, and it has responsibilities laid out for what everyone will do and how performance is evaluated, and these things are checked over time. So I might say, let us get some text to you and let you see it, and then say, you know, might be better if you think we need a companion document or something. We're very open to discuss that, but we're trying to put it all within one document. You know, some people have something called a policies and procedures manual, you know, and they have a big policies and procedures manual, and inside of that, they have a quality section. That's fine, and we could do that, but we're trying to call it a quality manual to really help in the field. So people in microbiology laboratories would say, like, you know, like that safety manual is the one place you go. We really want them to come and see what these standards are and operational standards for laboratories are like. So I may have messed up the words in the title a bit, but the concepts that you're mentioning, I think you're going to find are in there. And if they're not, we can discuss having more put to it. I've already made a presentation to FDA on this, and a guy you know, Tim Stencil. And so I've already talked to Tim about this. He's very excited about it. He's made arrangements that will be reviewed by the microbiological labs at FDA. They're very excited to look at it. And so if there are limitations in it in terms of operation, we certainly want to do it. But I think we're going to try to put that in the wording well enough that you'll be happy with it.
Okay, thank you.
Okay.
Thanks, Jim. I'm going to close out the session in a moment, give John some last words, but just did want to get, as we did last time for the Health Equity Working Group, although we're not going to take an official vote on the terms of reference, just wanted to get a sense from the committee about the need to move forward with this work. And if there's any objections, speak now, but otherwise we will proceed with the formation of the Laboratory Working Group and the official vote on the terms of reference next time. Great, I'm getting a good sense for the committee, so we'll move in that direction. And over to you, John.
Great. So I would just say that given the nature of the discussion, what we can, in the absence of voting on the terms of reference, I think what we can say to the working group is do form, focus on those 3 questions that were the first 3 that Jim laid out. We will gather more information about the feasibility of that 4th question. And in the meeting of the work group, there can be the other questions that have been raised in this discussion, including the ones that you raised, Jill. But the nature of forming a work group is a collaborative process that involves CDC reviewing suggestions as well as suggestions coming from the ACD. So before there can be a final vote on the terms of reference beyond those 3 questions, we would need to take any recommendation that came from the work group and go through our own review and clearance process at CDC. So it allows us to get started with the notion that we'll gather more input and have additional discussions, go through clearance, and then by the August meeting, the terms of reference should be available for a final vote, including by then we will know about that 4th question and whether or not it is included or not.
I have a question of, may I go ahead?
Sure.
Sorry. Just a question of protocol. So as we reach out to people now and ask them to join the work group, are we able to share the terms of reference with them, just so they know what they're going to be discussing? How does that work? Or do we just send the Federal Register? We could do this offline.
No, it's a good question, Jill. What we can share and will make public is the information that was in Jim's presentation. And that includes those 3 questions that I was just mentioning. The specifics beyond that, I think we want to hold off on until we finish the review and vote. But as we did with the health equity work group, it was often sufficient just to have the summary questions, the ones that really focused on where the activities would begin. And we've shared that in a public meeting today. And again, that will be available as a part of the public record as we make Jim's slides available on our website in just a few days.
Thank you.
Great, thanks, John. And Jim, thank you so much for spending this time with us. It was really helpful to get this grounding. This is to be continued for certain, but we're off to a good start and we owe that to you. Thank you. Okay, we're now moving to our last topic for the day. Play that little music mentally in your mind as we switch gears, because this is a really important update that we're going to be getting from the Health Equity Work Group. And also we do need to officially at this meeting vote on that work group's terms of reference. Boy, our co-chairs, Daniel and Monica, have been working hard since our last meeting. I've been watching them. It's been great to watch this take off. And so I'm going to pass the baton over to you to give us a bit of an update on the work that you've been doing and to set up the vote on the terms of reference. Over to you.
All right, well, thank you so much, David, and good afternoon, everyone. As you've heard, Monica and I are delighted to co-chair the Health Equity Working Group, and we are happy to be joined by 7 of our fellow ACD members who, as we heard earlier, are going to not only be doing double duty, but even triple duty, it seems, from the conversation we're having today. So I wanted to, next slide, please. I wanted to share with you the list of the 7 ACD members who are joining us. We have doctors Adamora, Michelle Albert, David Fleming, Rachel Hardiman, Rhonda Meadows, Julie Merida, and Octavio Martinez as part of our 7. And we want to thank you all so much for the privilege of your time and talents on this working group. Next slide, please. So as we heard earlier from the director, the Health Equity Working Group was really spawned owing to the CDC strategic plan on advancing science and health equity. And in October of last year, during our ACD orientation, we began the official health equity discussions to think about how we wanted to proceed with this, who we wanted to invite, where were the gaps and the challenges. And earlier this year, in March of 2022, once we had that figured out, we published in the Federal Register a notice soliciting nominations from people with health equity, public health science and practice, public health policy development, analysis, and implementation expertise. And we received, as you heard, quite an incredible number of nominations, those with frontline and field experience at local, state, tribal, and territorial levels, which we were excited about. After we received those nominations, we conducted 3 review rounds from March to April of 2022, right before we had our first official meeting on April 14. And the CDC team provided that technical review of all the nominations to ensure that they were eligible for further review and ranking. The CDC panel also helped us in terms of reviewing and ranking all the nominations based on those areas that we were looking for, and then made recommendations to Monica and myself, as well as ACD leadership. So who are these ACD folks? These are, of course, the co-chairs, our designated federal officer, John, our ACD chair, David, and Leandris and team who helped us review and rank these recommendations. And then afterwards, we chose 10 experts. There were so many incredibly talented people. It was extremely difficult. And so we had to push the envelope a bit and beg CDC to allow us at least 10 to join this group. And these are individuals who represent various groups, including issues such as disability, Alaska Native populations, homelessness, LGBTQ+ issues, corrections, or justice-involved individuals, as well as local and state public health and population experts. Next slide, please. So these are the 10 individuals that were chosen. We have Philip Alberti from the Association of American Medical Colleges, David Brown from YMCA, Nafisa Sise Abonye from Black Hawk County Public Health in Iowa, Carrie Freeman from the Dot Lake Village Council, Dot Lake Village in Alaska, Del Monte Jefferson from the Center for Black Health Equity, Maria Lemus from Visión y Compromiso and Network of Promotoras and Community Health Workers. We have Maishika Roberts from the Department of Public Health in Columbus, Ohio. Bonnie Lynn Swinner from Johns Hopkins University Disability Health Research Center. Paula Tran from the Wisconsin Department of Health Services, and G. Robert Watts from the National Healthcare for the Homeless Council. So those are our 10 individuals who have accepted, and we're really excited to move forward with them along with our 7 ACD member or 9 ACD members, including myself and Monica. So Monica, I'm going to turn it over to you next.
Thank you, Daniel. And I think we can move to the next slide. And while we're okay, it's up. Thank you, Daniel, for those updates. And just wanted to recognize that some of our HUE members who are not ACD members, I saw them on the participant list earlier. So thank you to all of the members who were able to join us this afternoon. As Daniel said, we had a good first meeting last month, and in terms of next steps that we agreed upon, just wanted to recap for the ACD members that the HUE agreed that between now and the end of this year, we will be meeting monthly. And so our next convening has already been scheduled for later this month. As Daniel highlighted, we were able to introduce the CDC staff who will be joining us on the HUE, and those include Dr. LaBird, Dr. Agus, John, David, you're on the ACD, and then Carrie Caldwell. So those are the core team members from the CDC who will be joining the HUE in our monthly meetings. And then, as Daniel said, and the director pointed out at the beginning of our meeting this afternoon, we received over 100 applications. And so we talked about figuring out ways to include or invite some of those applicants who clearly bring a lot of expertise and experience in the work of health equity to join us in potentially some of our monthly meetings. In between those monthly meetings, the HUE also agreed to bring together subgroups to help advance and to work on action steps in between those monthly meetings. And all of this with the goal of presenting a draft report to all of you at our November meeting at the end of the year. So the one piece that we do have to do is, as David pointed out, to approve the terms of reference. We approved the constitution or the convening of the working group in February, but this is one piece that we have to do on this call this afternoon. Next slide, please. You can go on to the next one. So before we go to the vote, just wanted to point out a couple of things. The first is that the original terms of reference, which we all received, nothing has changed in terms of the content of the terms of reference. What did change and what we have to vote on is specific language that allows us to increase the number of members. So in the original terms of reference, we had designated, I believe, 15 seats that included current ACD members, and we want to be able to increase that to 19. So that is the only change in the terms of reference. And then just to walk through fairly quickly, I hope, the purpose, just to remind ourselves of the purpose of the HUE, and really first and foremost to provide input to the ACD on the implementation of the CDC's core strategy, which Dr. LaBird did an encore for us at the HUE to walk through this really comprehensive framework and approach that the agency is using to address equity. The second is for the HUE to prepare reports with top-level findings, reflections, and outcomes that can further enhance the implementation of the CDC's efforts around core. Because we have a pretty diverse group of HUE members that will be able to bring into the conversations their experiences and in their respective organizations and working with different stakeholder groups on equity, really providing that innovative expertise and insights in terms of best practices and promising health equity practices from the field. And then finally, to bring ways to the ACD and to the agency around how to embed anti-racist policies and practices in public health programs across different types of organizations, by the way. Next slide, please. Because there were many different steps that were included in the original terms of reference, the HUE has agreed on emphasizing and sort of focusing on the first three, which you see on this slide. Again, to better understand what CDC will need to be successful in its core implementation, exploring perhaps what are the three top line cross-cutting core goals that could be adopted across the agency and across the different CIOs, and what are the most critical changes to advance these efforts. The second is to create opportunities for understanding what might be barriers to implementation and how we might work to support the CDC in minimizing or reducing those barriers, or at least addressing those, and additional resources that might be required to overcome them. And finally, given the work that's starting internally at CDC, how might those efforts advance and accelerate the work that we know is going on in the field across multiple levels of governmental public health? So I think at this point, I turn back to David for voting to approve the terms of reference and for discussion. David?
Thanks, Monica. Let's, if it's okay, just reverse the order of that, and would first open it up to the committee for any questions or comments or suggestions you might have from the presentation that we got, or on the terms of reference themselves before actually proceeding to a vote. You've, Monica and Daniel, you're doing incredible work, and I would suspect that there may be phone calls from the other working groups to you, given how you're leading the way here to sort of figure out the best way to do business. So I think that may be another duty, double or quintuple duty that you will be serving as we move forward. Octavio.
Thanks, David. David, the question might be for you, or maybe it's for John, but just thinking about health equity, and we had 109, I think I heard, applications. We only chose 10, and all of them were really just sounded like outstanding. I know that we have, the placements we're going to do, the openings for the other two work groups. Are they able to take a look at this pool as well as they're thinking about, especially since I know health equity is integral to all the enterprise, or do they have to reapply? I'm just wondering if there's any of folks that are maybe on the line thinking about the other two work groups. I'm not sure about the process.
That's an interesting and good question. I'm going to pass it over to John maybe, but at a minimum, if we were to do that, I think we would need to get back to the applicants, because they would be, in essence, solicited to do work group activity on another group. So John, what are your thoughts on that?
What I think we could do is notify them of the opportunity to apply to the two new work groups. We have the language that is in the Federal Register does say very clearly that there are certain procedures that must be followed in order to apply to either one of the other groups. So the fact that we know who they are, we have ways to reach them, I think suggested that perhaps we can contact them directly and see if there is an interest, and if there is, then encourage them to apply. So appreciate your thoughts on that, Octavio. I would also say for some of the members, there are other internal CDC groups where we've looked for external members, and we have shared their CVs with those groups, and they reached out to some of the applicants to see about their interest in being considered for some other activity. And the final thing I would say is, I think Monica mentioned this as well, that in terms of the possibility that there will be guest speakers that are brought in to the health equity work group, some of the people who applied, I think would be considered for an invitation to be an expert guest speaker who could present to the HEW. So I think there certainly are a number of different ways we might be able to follow up on those excellent candidates.
Thanks, John. Before calling for the vote, I just wanted to give Monica and Daniel an opportunity to speak to the terms of reference. You've been working with them for a while, and I'm thinking that you're comfortable with the way they are laid out now, but just wanted to affirm that with you or not.
Absolutely, David. So I'm highly satisfied with them. I think, they're flexible enough, but they're specifically focused so we're not boiling the ocean. So I'm quite pleased with what we've laid out in the TOR, and I'm happy to move forward. I have no concerns.
Agree. And I think we had good discussion with the HUE members about the terms of reference and sort of unpacking and prioritizing these first three. So I don't have any concerns or issues to share.
Great, thank you. And then, so with that, I would entertain a motion for adoption of the draft TORs that were sent to the committee as the final TORs that the committee will work under.
So moved.
Second.
Thank you, Rhonda and Octavio. Any further discussion on this issue? If not, would ACD members in favor of approving the TOR signify by raising your hand or saying aye?
Aye.
Aye. Fantastic.
Aye.
Any opposed? Any abstentions? The TORs passed unanimously. Congratulations. When we now have a working group with working TORs as well. Thanks very much, Daniel and Monica, again, for leading this discussion and also for your leadership on this work group. It's very exciting.
You're welcome, David. Thank you.
Okay, we're approaching the end. I'm going to turn this over to John for a moment to talk about public comment.
Thank you, David. We, as everyone on the advisory committee knows, I believe, we always allow time in our meetings for public comment, and we advertise that availability in the Federal Register. We request that people indicate to us ahead of time their interest in public comment, and you may remember in our February meeting we had a number of different folks who commented. We have not had any requests for public comment during this meeting. We will encourage, I think, all of those who are listening to this call to consider whether in the future meeting, in our August meeting or a November meeting, you wish to make a comment. Please follow the instructions that are on the website about how to indicate that interest, and we will make sure we have time for public comments again in the August meeting. But at this point, we didn't receive any requests, so that we don't have any people who've requested speaking during the public comment period.
Great, thanks, John. And while obviously we encourage public comment and would like to hear it, we do have a little bit of a gift of time today for this meeting. And so we're going to move on now to the closing. I'm going to start off and then I'm going to give the last words to John. First off, are there any comments from any of the committee members about the meeting, suggestions, advice on what we've covered today, or how we might do things differently and or better in the future? We're happy to receive that now, and as you think about it, comments offline as well. Seeing none, boy, we got a lot accomplished today. I wanted to give my thanks first off to obviously to Dr. Walensky for her clarity and specificity and talking about the important policies and progress that EDC is making. It was a great session. And thanks also to Dr. Mann who not only for her presentation today, but for her past work in COVID and for the future work that she's about to be doing for the agency. We're blessed in this committee to have the opportunity to hear about different aspects of CDC work beyond just our working groups, and really appreciate that. And speaking of the working groups, my goodness, so data and surveillance with Dan as the CDC lead and Julie and Nirav. Thanks so much for leading us forward on that, getting the terms of reference approved, and we look forward to filling out that working group and hearing about the progress at the next meeting. Similarly, for the laboratory working group, thanks to Jim for that unbelievable presentation and for the work that he's been doing on CDC laboratory and quality work, and to Josh and Jill for taking this on and leading us forward. Look forward to the vote on the terms of reference at the next meeting, but in the interim, the formation of the working group and beginning to move forward on the issues that have already been identified. And then on health equity, Daniel and Monica, certainly don't want to leave out Leandros and the CDC team as well, but you are leading the way, both in helping us and CDC do better on health equity, but also helping this committee and figuring out how to make the working groups as successful as possible. And so thank you for your continued leadership there. And thanks, I would be remiss if I did not express my appreciation to all of those people at CDC who helped make this meeting happen today. And more broadly, my goodness, for all of the work that's going on across this agency to keep me and my family and my community and you and your families and your communities safe and healthy. Thank you for that. And a special thanks to our DFO, John, who is expertly and tirelessly guiding the work of this committee, all the while having to put up with me. So over to you, John, for our final last words.
Oh, thanks, David. And I really want to echo your comments about how much has been accomplished already. This is only the second meeting of the advisory committee, and already we've got now 3 working groups that are going to be diving into critically important issues and issues where the CDC really needs to be advised and informed. Initially by the work groups, and those work groups will come back to the full ACD for your review, and then your advice to us on those areas. So we greatly appreciate that. A special thank you to those of you who have agreed to co-chair those work groups. That there is a significant amount of work that goes into overseeing a work group, and we really appreciate your stepping up to be able to do that. You know, I have to return the thanks, David. David and I, you may not know this, but we practically talk, every week more than once as in between the meetings, because there is a good deal of planning that goes in between meetings in terms of the work groups, the terms of reference, and other matters. So, David, really appreciate the endless hours you put in. I would like to thank the CDC staff, and just to mention some of the key people who are supports to you: Tiffany Brown, Carrie Caldwell, Bridget Richards, Heather Dunahee, Lauren Hoffman, Agnes Warner. Those are some of the key folks who've done really valuable work. I would like to say that at the August meeting, we do anticipate happily that meeting will be in person. We expect that will be the case. As you've heard David say, we would like to have the ACD members come in early so that we could have on August 8th a dinner. The meeting is planned for August 9th. So if each of you could look at your schedules now and begin to think about the travel arrangements that would be necessary for you to arrive in time for a dinner. There also is at least some discussion that we're open to entertaining about whether there could be certainly subgroups that meet on the 8th, perhaps with the co-chairs of the work groups. It may be each of the work groups may have over the course of the year one in-person meeting. So perhaps the HEW work group will be considering that. So let's have some follow-up discussions about whether or not it would make sense to consider that on August 8th. But August 8th, travel arrangements in time for the dinner, and then full meeting on the 9th, and then travel arrangements back. So for a number of you, that will take, that will mean a few days you have to block out. We anticipate that at the August meeting, we will hear updates on the 3 work groups, but we may also have time in the agenda for a more open discussion. And we've talked about that with David and with a number of you that you, in addition to your support for the creation of the 3 work groups, you also would like some time to be able to talk about some other issues, some issues that are of interest to you. And so we'll try to allow some time for that is less structured and more of an open opportunity. So again, just in closing, I want to thank you all. I think this has been a very productive meeting, and CDC is immensely grateful for the work of the ACD members. And I think we'll see over the course of the year the benefit of your input and expertise. So much thanks, and back over to you, David.
Well, thank you, John. And our last words are my great appreciation for all of the members of the ACD that are investing your time in making this work. And with that, we are adjourned. See you next time.